Okay. All right. Hopefully everybody is good to go. And sorry we're starting a couple minutes late. We had a slight technical difficulty. And let's see. All right, hold on, guys. There we go. Okay. All right, just making sure we're good over here. So, wouldn't be me if it wasn't a little chaos. So, hi, hello, and welcome to G-PACT's third annual conference. Yeah, see, here we are, starting strong. So for those of you that don't know my chaotic self, my name is Samantha. I am the president here at G-PACT nonprofit. I'm very excited for today, and we have a great lineup of speakers. Um, let's see. I have a paper in front of me, so apologize for reading that, but there will be a Q&A for each session except for our panel discussion and the intermission. There should be a Q&A box for everybody, so if you have questions, you can throw it into the Q&A and we will get to it at the end of each session. We are recording today's session, so if you aren't here live, I'm sorry you couldn't join us, but we will have the sessions later and up on our YouTube channel. We ask also that you have no note takers on, so please be mindful of that. And now to get us started, I'm going to introduce our first speaker. Her name is Sarah. She is a current volunteer with G-PACT and will be co-leading our Patient Advisory Council with us. She's a wonderful volunteer and an even better friend. So without further ado, here's Sarah.
Thank you, Sam. Hello, everyone. I'm really excited to be here and truly honored to have been asked to share my story. I do have slides that I think Sam's going to help me with because I was the problem. I had the technical difficulties this morning. So it's just okay. So you can go to the next slide as I begin. So my name is Sarah Lustgarten-Bellah, and I've been living with gastroparesis for about 20 years now. And even saying that out loud still feels a little bit surreal. In a lot of ways, I still feel like the same 9-year-old girl that you see here on the slide. But in other ways, I feel like I've lived an entirely different lifetime inside of this illness. So, whenever you're ready for the next slide, Sam, my story starts back in 2005 when I got what we just thought was the run of the mill stomach virus. And before then, I really was your average 9-year-old. I loved to sing and dance and ice skate and just be carefree. And in looking back, I did have some underlying issues. I've dealt with chronic migraines and some mild dysmotility in the form of bad constipation from birth, but nothing that prepared us for what was about to happen. And so, even though this virus I mentioned was bad enough to land me in the ER, it was still standard. It was the type of thing that comes and goes, except mine didn't go. When the week was over and the virus had run its course, there were symptoms that lingered: nausea, vomiting, severe abdominal pain, bloating, no appetite, early satiety, weight loss, malnutrition, brain fog, dizziness, all of it. And all of those symptoms that started 20 years ago have never really left. And as you can imagine, living like that every single day made it really hard to function normally. I was missing a lot of school, losing interest in the things that I loved, and my world started to get smaller very quickly. And I think that was one of the hardest parts because when you're that young, you don't have the language to explain exactly what's happening to you. You just know that your life doesn't look like everyone else's anymore. You're missing birthday parties, you're missing after school activities, you're missing the things that make you feel like a normal kid. And at that age, you definitely don't understand chronic illness. You just kind of feel left behind. So my parents started taking me to doctors, and we quickly became extraordinarily frustrated with what we were told. I had doctors telling me that I had an eating disorder, that it was anxiety, or that it was all in my head. And at that age, you don't know enough to question that. You believe the adults in the room, the professionals, until your body tells you otherwise over and over and over and over again. There were very few doctors who would give me the time of day, and very few people specialized in this. And honestly, even now, today, there are still so few people who choose to specialize in this space. Countless doctors sent us home saying that there was nothing wrong with me. And my incredible parents searched everywhere, locally, nationally, even internationally, just trying to find somebody that would listen to us. And I know that I'm not the only one who has experienced that. I know so many people in this Zoom and beyond it have been told the same things and felt the same frustrations and questioned themselves in that same way. And that's one of the hardest parts of this illness is how isolating it can feel, especially when it's misunderstood. So for us, this search eventually led us to the Children's Hospital of Philadelphia, where I began my journey. And again, this was around 2005, and gastroparesis was not something that was widely recognized or understood. So I went through what felt like every test under the sun. Some of them were pretty invasive, which in hindsight is almost ironic because in the end, all it took was eating scrambled eggs and laying under a machine to finally get an answer. But it was 2 years of testing before I was officially diagnosed. And those 2 years felt really long, not just physically, but emotionally. Because when you don't have answers, you start to question everything. And as a kid, you start to internalize what people are telling you that maybe it is in your head. Maybe you are the problem. Maybe you are being dramatic. So, getting a diagnosis didn't just give me a label, but it gave me a sense of trust back in my own body. And I'll never forget that day because, of course, nobody wants to be diagnosed with a chronic illness, especially as a child, but really at any age. But at the same time, it meant finally that I had a name for what I was experiencing, and it meant validation. And most importantly to me, it meant that it wasn't all in my head. There was a reason that I was feeling this way, and there was somewhat of a path forward. But even with the diagnosis, things did not just suddenly get better. Over the next few years, my symptoms continued, and in many ways, they worsened. I was also diagnosed with comorbidities like POTS, postural orthostatic tachycardia syndrome, part of a group of conditions called dysautonomia, and hypermobile Ehlers-Danlos syndrome, which is a connective tissue disorder, both of which have only added to the complexity of my case. I tried countless therapies, procedures, medications, some that were compassionate use only, others that were originally approved for completely different conditions and just repurposed in the hope that something might work. I've had so much imaging done over the years that my family likes to joke that I probably glow in the dark. And even with all of that, there really wasn't much back then that could give me lasting relief. I was missing a lot of school. I lost friendships because we all know how understanding middle and high schoolers can be. And I spent so much time at CHOP that I probably knew more nurses' names than classmates. I was not thinking about sleepovers or school dances. I was thinking about IV lines, medications, and whether or not I could tolerate just a few sips of water that day. And eventually, as my weight and nutrition declined, I was given an NG tube, not this one, obviously, which later became a GJ tube in my abdomen. At first, this helped me stabilize enough to return to school. Sometimes that was a few days a week, sometimes that was just a few hours a day. But then my body started to reject the feeds. Even when they bypassed my stomach, I couldn't tolerate them. And that's when things got really serious. And we can go to the next slide, Sam, please. I was hospitalized for a long period of time, and my levels were in dangerous territory. And we were trying to avoid organ failure. So I had my first PIC line placed and began TPN, which, for those of you who don't know, is nutrition given intravenously to bypass your GI system entirely, which comes with its own slew of risk and responsibility. And I do wish I could give you a clearer picture of what this time in my life looked like, but the truth is, a lot of it is very blurry. And I do think that's probably my brain's way of protecting me from how difficult it really was. But what I do remember is how serious it was. I remember how scared my parents were. I remember how fragile everything felt. And I think that was one of the first times that I realized this was not something I was likely just going to grow out of. This was something I was going to have to learn to live with. And even with the incredible care I received, it became very clear that there was a huge gap in this field, a gap in understanding, in research, in available treatments, and even in equipment at the hospital that I was being seen at. And so that's what led my family in 2011 to open the Susie and Scott Lustgarten GI Motility Center at CHOP. The goal there was to expand care and research for kids like me who felt sick, frustrated, and alone. And over time, things slowly did begin to change. As the science progressed, new treatments became available, and I started receiving Botox injections into my pylorus to help with emptying. And combined with the right medications and adequate nutrition from the GJ tubes and the PIC lines, I finally reached a place of relative stability. And honestly, the amount of Botox I have had over the years, it's pretty impressive considering none of it was cosmetic. And I don't think I have too many wrinkles yet. So I feel like maybe we're onto something there. But for the first time in a long time, after all of that was in place, I felt I was able to try and re enter my life as an adolescent. And that might sound simple, but it definitely did not feel simple. It felt like learning how to be a person again. I had to relearn how to show up, how to make plans. But most importantly for me, I had to learn how to trust my body, even if that was just a little bit at first. And even then, everything came with limits. But it was the first time I realized that even within those limits, I could still build a life. And despite everything, I did keep going. We could go to the next slide. Other way. I went back to school. I graduated high school. I went to college, although it took me some extra time to graduate because I had to reduce my course load to balance my health. I got my master's degree, again, through a hybrid remote program that worked for my health. And I got married last year, which is something that I once honestly was not sure would even be possible for me. Because when you're sick for so long, it's hard not to let that become your identity. But those moments reminded me that my life could still expand, even within the constraints of my illness, that I could still grow, still build, still move forward, just a little bit differently than I once imagined. And then that became a recurring theme in my life. Even then, there was never a point where I was cured or normal. I mean, who is normal anyway? Though there are many days in the last 20 years that I haven't had symptoms. And since 2007, I have not had a single gastric emptying study come back normal because chronic means chronic. And while I was tube free for about 10 years, chronic illness isn't linear. And even after long periods of stability, things can shift in ways you don't expect. And about 9 months ago, they did for me. If you go to the next slide. 9 months ago, I had a flare. Just, didn't think much of it. Happens to me all the time. And normally, when I would have a flare like that, I would go in for my endoscopy with Botox injections and be totally fine. Not totally fine, but back to my baseline within a few weeks. So I went in thinking nothing out of the ordinary. I had the routine endoscopy. 2 weeks passed, then three, then four, then five. And that's when we realized that the Botox had stopped working. So I had to get an NJ tube placed again after being years, so many years tube free. And the day after my birthday this past year, I underwent the G-POEM procedure, which is essentially a more permanent way of helping the stomach empty better. And even now, as you can see, it hasn't been a perfect fix. But what that experience reinforced for me is this: when things change and when treatments stop working, when your baseline shift, it does not mean that you failed. It just means that you're continuing to adapt. And that's really the reason I'm telling you all this. Not just to share my story, but to show the contrast between then and now and what it has all taught me. Because beyond everything I've gone through physically, there's also been a whole other side of this journey, which is how I've learned to live with it. We can go to the next slide, where I'm going to talk about how I have experienced both sides of this spectrum. So there was a time in my teenage years when I was in complete denial. I didn't want to be in a hospital anymore. I so badly wanted to be normal that I pretended nothing was wrong, to the extent that I could. I was flushing my medication down the toilet and convincing myself I didn't need it, which, as you can imagine, did not last very long before things unraveled. And I think that phase came from a place of pure desperation because when you've spent so much of your life feeling different, you just want to fit in with your peers. And then there were other times where I felt the complete opposite, where I let my illness become my entire identity. I felt completely broken. Like I was someone who could never be fixed, someone who would live a very small and a very isolated life. And for a while, I did isolate myself, and life got really dark. And when you're in that place, it's very easy to believe that your life is going to stay that way forever, that this is all it will ever be. And that's a really hard place to come back from. And it took me almost 2 decades to find some kind of balance between those two extremes. Next slide. So it took me almost 2 decades to find the balance between living with chronic illness and learning how to live alongside it. And I think that's something I really want to take a moment to break down because it looks different for everyone, of course. There is not one right way to do this. Not everyone's baseline is the same. Not everyone's abilities are the same. And that's okay. That's more than okay. That's what makes us individuals. But I truly believe that everyone is capable of finding a version of life that still holds joy, even if that joy looks different than it once did. Even if it's a little smaller, a little quieter, it's still there. And learning how to see your life through that lens, to find the meaning in the little things and to build a life that works for you instead of against you, that's where that shift happens. And somewhere along the way, that shift didn't just change how I lived, it changed how I defined what it means to live fully. And I used to think living fully meant independence, spontaneity, productivity, doing everything, saying yes to everything, keeping up with everyone else my age. But now I understand it very differently because now living fully to me means being present, it means adapting, it means celebrating small wins, as cliche as that may sound. It means choosing what matters and letting go of what doesn't, because my life didn't get smaller, it just got more intentional. And living fully for me means building a life that can hold both grief and joy at the same time, because the truth is, with all of this, both exist. There are still losses, there are still hard days, there are still moments that feel anything but full. And yet, there's still connection and purpose and love in my life. But what I've come to understand, really understand, is this. Next slide. Living fully with chronic illness does not mean doing everything. Does not mean being positive all the time. And it definitely does not mean overcoming your illness. That is not what makes you strong. Next slide. It means redefining what full looks like to you. It means honoring your limits without shrinking your life. It means finding meaning within the constraint, not outside of it. And so, next slide, final slide, I think. And so, my hope and my ask is that we all keep going, whether you're a professional, you're a patient, anyone here listening, because that all of us, in whatever role we're playing in this space, we need to continue pushing things forward. We need to continue to push for better research, better treatments, more understanding, more access. Because for so many people, those things aren't just improvements, they're the difference between existing and actually living. And something I've come to understand over time is that when you're treating a patient, you're not just treating the patient, you're treating all the people that love them too. And one of the hardest things for me growing up through all of this was watching the toll it took on my parents and now my husband too, and really my whole family. Because when someone is sick every day of their lives, whether you can see it or not, it's impossible not to feel the weight of that on everyone. So every step forward in this field matters more than you know, not just to the patients, but to everyone who lives this with them every day. So truly, from the bottom of my heart, thank you for listening. And thank you for being part of a future that I know will look very different than the past.
Did I click you off too soon?
Nope, that was it. That was my ending slide. I'm not a graphic designer.
Oh,
Claim to be.
thank you, Sarah. So, we've got a couple questions for you. And let me just get you up on the screen so your face is what everybody can see. So, first question is, if someone could spend one day in your body, what do you think would surprise them the most?
Well, I don't find this to be too dissimilar to anyone experiencing chronic illness, but I think what would surprise people the most that maybe don't have these issues is just how constant it is. It's not just bad days, it's every day in some capacity. And even on my best days, I'm still navigating symptoms and making decisions and adjusting in real time. And I think what's even more surprising is how much of that is invisible, because from the outside, things can look completely normal. People tell me all the time, "Oh, but you look great." Yeah, I'm sick. I didn't say it was ugly. No, that was a bad joke. But internally, no, there's a constant calculation happening. What I can eat, how much energy I have, what plans I need to cancel, what I absolutely need to force myself to push through. And over time, it becomes your normal, which is both incredible and incredibly hard at the same time.
Thank you, and, we always welcome those jokes. We've got another question. This, person missed some of your story, but, wondered about your experience with TPN, and I know you did mention that. Do you
Mhm.
mind sharing a little bit more about, how long you were on it and what your experience was?
Yeah. So TPN, I was on TPN the shortest amount of time out of all of the devices and things that I've had, tubes and all of that. I had my first PICC line placed in 2011. I was about 13, 14, and not in the best mental space. So this is really the period of time where it gets very blurry. And I was trying to look through my records when I was putting this all together. So I don't think I was on CPN any longer than a year with even a break in between. I came off of a PICC line and then I had another PICC line placed. It could have been closer to 2 years. I really don't know. I don't wish that I remembered more, but I am very lucky to have the parents that I have, and they dealt with all of that for me. I mean, they were mixing my medication, they were doing everything for me. So, a lot of that period of my life is fuzzy, and I wish that I had more specifics for you there, but I don't. But it wasn't any longer than a year or 2 that I was on CPN.
Thank you for sharing. So I've got another question. What are some coping skills that you use to get through a bad day or a bad flare? I know you touched on that a little bit, but
Yeah. So, I mean, there's obviously medications and products and things that I've tried and collected throughout the years, but I don't want to sit here and just give you suggestions because what works for me is not going to work for you. So I think really the focus is more on the mental here and how you have to be really intentional about how you structure your life. A lot of it comes down to pacing and understanding your limits, planning around them. I try to build flexibility into my routine just because I know my symptoms can change day to day. I've learned how important it is to prioritize what actually matters to me, instead of trying to keep up with what life is supposed to look like. Um, One of the biggest tools I think has just been self awareness, knowing my body well enough to make these adjustments before things spiral out of control. Um, it's still a work in progress. I mean, on bad days, I try to take pressure off of what I should be doing and focus on what I can do. And sometimes that looks like resting without guilt, but that's something I still struggle with. I still get the guilt. And yeah, I don't know. I think it's just pushing. It's less about pushing through and just more about adapting in a way that's sustainable.
thank you. We had a couple questions just pop in. So if we have time to get to them all, I'll go quickly. I've not heard of the G poem before. What was your experience when learning about this procedure?
So, obviously, you need to reiterate I am not a doctor. So, everything I'm saying, please check with your physician. But from my understanding, what a G poem is essentially it's a surgery done endoscopically, and they go in and they cut the pylorus muscle in order to allow empty food to empty out of your stomach easier. Now, because I had such great success with getting Botox injections in my pylorus for so many years, which what that does is it relaxes the same muscle. They felt that the G poem would just be a more permanent solution to what had already been helping me for a decade. Um, and so I went in. I had it done on Halloween, actually, day after my birthday, this past October, and of course, the hope was I would do the 12-week recovery and be tube free again and back to my baseline. Things aren't always the way that you plan them out to be. I have had some relief. Absolutely. I've had relief from the procedure. I don't think it was a quick fix. I think there's still options to explore, but that was my experience with the G poem. But everyone's experience is different.
Okay. We've got time for I think one more question, and then there are a few in the Q&A, Sarah. So if after we're done, if you want to type the answers in there so everybody can see. But we'll do one more live that said, Did you deal with more stomach dysmotility or intestinal dysmotility or a combination of both?
So definitely a combination of everything. Um, as I mentioned, from birth, I had really bad constipation to the point that, I'd have to go in for help. After I was diagnosed with gastroparesis, so my symptoms really kicked into gear. The focus was primarily on my stomach. I don't know that we even realized that I had full intestinal dysmotility until I started doing J feeds, J tube feeds, bypassing the stomach. And still I was having, still to this day, I have issues tolerating the feeds sometimes. So I think it's definitely full and, dysmotility throughout the entire GI tract, um, which can be confusing when you're just saying gastroparesis. So I should be a little bit more careful with my terminology.
Well, thank you so much, Sarah, for sharing your story. I know, like I said, we've got some questions in the chat still, which she will be answering for us afterwards, but we are out of time to move on to our next speaker. So right now we have Robin Cook. She is a registered dietitian with a lot of experience with medically complex patients. She's currently part of the medical affairs team at Nestle Health Science, and today we'll be talking about practical approaches for formula selection for gastroparesis patients. And just like with Sarah, once she's done with her presentation, we will do a Q&A at the end. So Robin, go ahead and take it away.
Thank you so much, Sam. I'm just trying to figure out the share sound here, which is not working. Well, hold on. We're going to close this and try again. Good morning, everybody. We'll give you a second as we work through the
It's okay. We've had technical
technical
difficulties.
difficulties. Sam, do you know how to get the share sound option to it? Like,
Let's
it won't let me click on it.
um this is a learning curve for everybody. As I said
I
when we logged in, it wouldn't be me.
know. If everything was perfect, right? Oh my
If you hit
goodness.
share, you should be good.
Okay. So usually you have to click share sound so you'll be able to hear the videos, but that's not letting me click that option. So we're gonna try, and then when we get to videos, give me a shout if you can't hear anything, and we'll try again at that point, if that sounds good.
Yeah.
I might have to take the headset off, which is what we might just do. All right. Good morning, everybody, and thank you so much for joining us. And I'm so happy to be here and talk to you all about this. The title of my presentation is "A Way Forward: Practical Approaches for Formula Selection and Gastroparesis." And so, what we're going to do today is go through a little bit of a review of what is normal digestion and how this differs for individuals with gastroparesis. And I find this particularly important. I always took this route when I was doing nutrition counseling when I was at CHOP. And part of that is because I just think about myself and I always want to know why something works the way it does and why something that someone recommended would be the thing that they recommend. What makes them think that that's going to be successful? And I think the first step to that is understanding what it does within the mechanisms of both normal digestion and then how that differs in someone with chronic disease. So then after we talk through that, we're going to go through the different classes of enteral formulas. So they're not all enteral formulas are not created equal. So we're going to talk through what some of those formulas are and then how specific ingredients within those enteral formulas may affect tolerance. And then within that, the reason I was trying to share sound is I do have a recording from a patient who's on one of the formulas that has gastroparesis and was going to share her story with you. So hopefully we'll be able to get that to work. All right, so digestion of food is a codependent process. So each phase of digestion, from the salivary stimulation in the cephalic phase, and that cephalic phase is actually where the smell, sight, thought, and even the taste of food actually triggers your vagus nerve to start preparing the stomach for digestion. Right through to absorption, which happens in the intestinal phase, all requires an orchestrated, timed reactions of enzyme release, breakdowns of food, and muscle contractions which then propel food through the GI tract. The further along the food gets in the GI tract, the more it gets broken down so that eventually it gets absorbed into the bloodstream. And once those nutrients are absorbed into the bloodstream, they will be transported into the cells of the body for immediate use or stored for later use. And then what isn't absorbed is eliminated as waste. So gastroparesis, as I'm sure many of you know, is also known as delayed gastric emptying. And this occurs when the stomach has trouble clearing out its contents in the absence of mechanical obstruction or a blockage. So the condition affects the nerves and muscles in the stomach, and it interferes with muscle activity, which is also called peristalsis, that would normally move through food through the stomach and into the intestines. And as a result, the stomach is not able to process food and it holds up that whole digestive process. So this occurs in about less than 0.2% of the population, and more commonly in women than in men. Symptoms basically stem from what the disease is. So not only things like lack of appetite and feeling full and nausea and vomiting, but also things like reflux disease or chronic cough or laryngitis just from having food that's persistently in your stomach that then makes its way up back into the esophagus. And the goal of medical therapy is to alleviate the symptoms as much as possible, to correct any malnutrition that comes from not being able to consume adequate nutrition, and when possible, to be able to resume oral intake to some or a full degree. The cornerstones of treatment include medications like prokinetics, antiemetics, optimizing blood sugar in patients who have gastroparesis that's related to diabetes, and ensuring that adequate nutrition is provided. As you heard Sarah talk about her story, there's also several types of surgery or medical procedures that aim to sort of stimulate the stomach muscles or allow food to pass from the stomach to the intestines more freely. Other technologies include gastric electrical stimulation, which involves implanting a device that stimulates the stomach muscles. And this has shown mixed results, but may improve symptoms in some patients. And then lastly, several therapies that target the pylorus, which is that muscular ring between the stomach and small intestines to allow food to pass more freely. As Sam said, I'm a dietitian, so our focus for today is going to be on the nutrition strategies, and then we're going to narrow that even further. So, about 64% of patients with gastroparesis consume caloric deficient diets, and that's defined as less than 60% of estimated total energy requirements. And as you can imagine, if you're missing about 40% of what you need, that's going to potentially lead to weight loss and then malnutrition, which comes with a whole other host of issues. And then vitamin and mineral deficiencies are also common. So most commonly vitamins A, B6, C, K, and K, and then the minerals iron, potassium, and zinc. The goal of nutrition therapy is really to maintain or return optimal nutrition status. And as you just heard, malnutrition and nutrient deficiencies are common, as those symptoms will interfere with the ability to consume adequate nutrition. So if we go from that largest ring, we get sort of progressively more nuanced and invasive the further we go. So starting with a regular diet, things like small frequent meals or small particle size, so things like mashing or blending food. There's also been some studies that have shown that the emptying of liquids is not as affected as it is with solid food. So increased use of oral supplements or more liquid meals. Next, in that purple box, we have enteral nutrition, which becomes recommended if the oral diet is not meeting nutrition needs. And then lastly, parenteral or intravenous nutrition may be utilized in some cases, especially in those with severe malnutrition. And that method actually completely bypasses the GI tract. So nutrients are delivered directly into the bloodstream with no need for the stomach or the intestines to do anything. Okay, so as I said, we're going to focus even further now into those nutrition therapies and spend the rest of the time talking about enteral nutrition or tube feeding. So enteral nutrition is administered through an enteral access device, which is also called a feeding tube. And there are a multitude of different types. So there are tubes that start in the nose and they end either in the stomach or the small intestine. And those are called nasogastric, nasoduodenal, or nasojejunal tubes. And how you can sort of remember is the first part of all of these names is where it starts. So nasal being the nose, and then the second part of the word is where it terminates in the GI tract. Next, we have tubes that are placed through the mouth into the stomach. So that's orogastric, or in the small intestines, and that's oroduodenal or oral jejunal. And then lastly, there's tubes that are placed directly through the skin into the stomach or small intestines. And that is called a gastrostomy, or if it's in the intestines, a jejunostomy. And then there's also a tube that's called a gastrojejunostomy, which has two different ports. So there's one port that terminates in the stomach, and then one that will terminate into the jejunum. Enteral nutrition provides the nutrients that are required when individuals cannot consume enough food or nutrients that are needed to maintain health or recover from disease, illness, or a condition. It helps to maintain normal digestion and absorption of nutrients through the GI tract, which is necessary for proper bodily function. And it also comes with significantly less risks than doing parenteral nutrition. So when you start putting in something like a central line, you increase the risk of infection and electrolyte abnormalities and different things like that. And so enteral nutrition is really still using your GI tract, which is always the goal if that is possible. Enteral nutrition also can support the immune system and can be associated with the reduction in infections. And then it can also help in the prevention of malnutrition and also treats existing malnutrition. So not all formulas are created equal. I kind of said that at the beginning. So not only are there different classes of formula, but there are also nuances and differences between formulas within the same class. And this is where at the beginning I said I think that an understanding of physiology then helps you kind of understand what do the specific classes of formula, what are they used for? And then within those classes, what does the composition of the formula, how can it benefit you depending on what your conditions are? So we're going to spend the rest of the time talking through some of the different classes of enteral formula. So first, we have what is called standard enteral formulas. So you can see some options over here on the right side of your screen. And standard formulas contain intact protein, so protein that it's in its full form, with balanced amounts of the macronutrients, which include carbohydrates, protein, and fat. Typically, they're somewhere between 45 and 50%, 55% carbohydrate, about 12 to 20% protein, and then 30 to 40% of the calories from fat. The protein sources varied. So there's milk-based options, there's soy-based options, and then there are a whole slew of plant-based options as well. And they're typically for use in people with a completely functional GI tract. The caloric density varies, so it ranges from 1 to 2 calories per milliliter, which essentially translates to about 1,000 to 2,000 calories per liter of formula. Right? So the higher the caloric density, in theory, the lower a volume that you would need to meet your calorie needs, though that can come with some nuances there because they increase, the higher the caloric density, it increases what's called osmolality, which is essentially how much of the nutrients are there in relation to water. The higher that number, the slower the stomach will tend to empty. And when you're feeding into the small bowel, sometimes that can contribute to some intolerance symptoms, in particular diarrhea and abdominal cramping. And then they all come with and without fiber, depending on which version you're choosing. So the next category we have is what's called peptide-based formulas. The terms semi-elemental, partially hydrolyzed, and peptide-based formulas are all interchangeable. So there was a paper that was published in 2016 in a journal called Nutrition and Clinical Practice, where peptide formulas were defined as enteral formulas with partially hydrolyzed macronutrient content, and that essentially means broken down. So the nutrients were not in their intact form the way that they are in standard formula, and that they're designed for patients who have GI dysfunction or those who've had difficulty absorbing and digesting standard polymeric formulas. So what actually does intolerance mean? So enteral feeding intolerance is defined as GI symptoms during tube feedings, and that can include things like diarrhea, constipation, bloating, nausea, vomiting, belching, flatulence, regurgitation, and just abdominal pain or discomfort. And the presence of one or more of these symptoms can signal that a formula is not being tolerated and that another choice might benefit you more. So there are components of peptide formulas that make them different from standard formulas. The first is that the protein is typically partially broken down, and that's going to make digestion easier and more efficient. Peptimin actually contains a high percentage of what's called di and tripeptides. So that is protein chains that have 2 to 3 amino acids on them. Amino acids, remember, are the building blocks of protein. So a bunch of amino acids linked together creates an intact protein. And then when they're in smaller components, like 2 or 3 chains, those actually can be more efficiently absorbed in the GI tract, in particular when it's inflamed or is otherwise compromised. And that's actually more efficient sometimes than a completely broken down formula that is just those single amino acids. Next, the type of protein source. So if we think about milk protein, there's 2 types of milk protein. There's casein and whey. Casein is the part you make cheese out of. So it actually curdles when it comes into contact with the stomach acid, and it empties significantly slower than whey protein, which is going to remain liquid in the stomach. In addition, the whey protein has a high amount of branched chain amino acids, which make it important for things like tissue repair and for growth for pediatric patients. And then what I do want to note is that peptimin, remember I said that there's nuances even within these different classes of formula. So peptimin is the only peptide-based formula that has 100% whey protein. The other formulas on the market have some combination of casein and whey. And then the last thing that makes these peptide-based formulas unique is that they have what is called medium chain triglycerides. So that is a type of fat. So there's long chain triglycerides and medium chain triglycerides. And the MCT is actually directly absorbed in the small bowel. So it becomes more efficiently absorbed and can be used as a quicker source of energy. It's also been shown in the research to help facilitate and improve tolerance. So eliminating some of those enteral feeding intolerance symptoms that we talked about a little while ago. Okay, so here we're going to see, Sam, tell me if you can hear this, because this is a video. If you can't, I'm going to just disconnect the headset and we'll try again. Are you hearing that?
Nope, I didn't hear any.
Okay. We're going to stop sharing. Give me 1 second, everyone. Still not working. Okay, I might just have to tell you what it all says.
That's okay.
Okay. All right. Well, this is going to be significantly shorter than it was then. Okay. Essentially what the video shows, we're just going to go to the next one from current slide, is how essentially the difference between whey and casein. And I actually inserted a picture, so now I'm glad I did, so I can show it to you this way. So essentially what happens when casein is exposed to an acidic environment, so something like the stomach, where in this case, the formula was exposed to a pH of 4.5, so a little bit higher actually than the normal pH in the stomach, for about a half an hour. And what you can see is the formula on the right over here actually has casein in it. It's about 30% casein and 70% whey, and you can see that it actually curdles when it's in the stomach. The peptimin products here on the left actually contain all whey protein. And so even when they're exposed to acid like that, this formula stays in that liquid state. So it does tend to empty significantly faster from the stomach. It's also more efficiently absorbed in the small bowel. So not only because of those smaller protein units called peptides, but also because of the whey protein itself, it's more efficiently absorbed. So peptimin and peptimin junior themselves have actually been studied in 24 different disease states, that it does include gastroparesis. And there are a number of different peptimin formulas for both children and adults. So there's some that have fiber, some that do not have fiber. They come in a variety of different caloric densities, anywhere from 1,000 to 1,200 to 1,500 calories per liter. And then there are some that contain omega-3 fatty acids, which are actually come from fish oil. And those actually can help with modulation of the immune system, especially when patients are very sick. All the peptimin formulas, though, regardless of the nuances of fiber or caloric density, all have that 100% whey protein. They have the high percentage of those smaller peptides, and then they have a high ratio of MCT oil. So if we look at this study was published in 2025 and explored the outcomes of pediatric patients with gastroparesis. And what it found was that when the patients were switched to Peptimin Junior, they had a reduction in GI intolerance symptoms, reduction in what's called healthcare resource utilization, and cost savings. And we're going to talk about what that means in a minute. So specifically, after they were switched to Peptimin Junior, the children noted a 56% reduction in abdominal distension, which is sort of essentially It's almost if you picture like a little 2-year-old after they eat and their belly kind of gets bigger after they eat. That is what abdominal distension is. And that tends to be less predominant or visible as you get older. So it's pretty common to see that in babies or toddlers. But usually as you get older, that doesn't happen as much, except when there's that intolerant symptom and the stomach is not emptying very efficiently. They also saw a 56% reduction in flatulence and then a 28% reduction in nausea and vomiting. In addition, there was a reduction in costs that were associated with outpatient visits and emergency room visits 6 months after the change, and a reduction in the number of inpatient admissions 12 months after the switch. And to most individuals who are using the formula, relief of the GI intolerance is often the most compelling result. But for any of you, and I'm sure it's a lot of you who have spent time dealing with the insurance company, the decrease in the healthcare costs associated with the use of a particular formula is often helpful in convincing the insurance company to provide coverage for something like that. Because it means that maybe they're going to pay a little bit more on the front end, but any sort of enteral products or nutrition intervention is going to be less expensive than a hospitalization or repeated visits to the emergency room. Okay, now this is the part that I'm sad you're not going to be able to hear, but I'm going to try to sum up as much as I can. So this is Lisa and her husband Rick and her 2 boys, and we have something at Nestle that's called the Nestle Health Science Connections Program. And this is we have patients that will often contact us to just tell us how they're doing on a particular formula or ask questions or things like that. And in this case, Lisa had contacted us just to tell us what her positive story was from using Peptamen. And part of the reason that we do this as Nestle is that everyone who's at Nestle is really trying to remember the why behind what we do. So at the end of all of the research and all of the products and all of the education that we provide are patients like all of you or families like all of you who have been struggling through this sometimes for years and years and years. Or it's new to you and it's scary and you don't know what to do or where to go. And so what it helps is for everybody to really understand how it is the products help and why we're doing what we're doing. So Lisa was actually diagnosed with gastroparesis in about 2003, and she ended up getting down to about 84 pounds at her diagnosis before they were able to figure out what's wrong. And she spent almost the next year in the hospital on TPN before she was able to get a gastrojejunostomy tube. So that's the one where it goes in your stomach, and then also there's a port that goes into your small intestine. And part of the reason that she needed TPN was her gastroenterologist had wanted her to get up to a particular weight before they were able to put the tube in. And what you'd hear her say in the story is that she just kept hearing she didn't feel great on TPN. She was in the hospital, she had kids, she really thought like this was kind of it for her and she was going to end up with a nursing home and that was going to kind of be the end. And her doctor kept telling her, just wait till we get the tube, wait till we get the tube, and we're going to start you on this formula called Peptamen. And I'm laughing because she would say, like, God, this Peptamen, it must be the greatest thing ever because really I feel terrible right now. And she finally got up to the weight she needed to be on her TPN. And she was able to start the tube feeding. And what you hear her say in the video is that one day she just woke up and felt good. And she hadn't felt good for going on 2 years at that point. Rick and she own a business, and she woke up that morning and told Rick she was going to work, and he kind of looked at her like, "Are you kidding? You haven't done any of that in a year." And she was finally able to go to work and she felt like she got her life back. And now she has this tube and she uses it every night. Rick actually is in charge of pouring the formula in the bags and getting the pump all set up. And then she does her feedings into her small intestines with the Peptamen overnight. And she does everything. She's back to being a mom and she has her kids and she and Rick own a business and they travel and sort of that story that just, when you find potentially the right product for you or you keep pushing or whatever, hopefully, you get to the point where you get your life back and you're able to do some of the things that you did before the diagnosis. So I had a whole 6 minutes for for her to talk about that unfortunately you don't get to hear, but that's essentially the story that she was going to tell. Yeah. Okay. And then the last class of enteral formulas we're going to talk about are the real food containing formulas, or what's called blenderized formulas. And these are defined as the use of blended foods and liquids that are administered through a feeding tube. And they consist of both homemade blends that you can make at home. And then there's also quite a variety now of commercially prepared products that are on the market. And it is that latter group that we're going to discuss in a little bit more detail. So real food based enteral formulas have a number of advantages. So first, they offer a diversity of nutrients that come from a variety of real food ingredients. There are research to suggest increased quality of life and also improved clinical outcomes from their use. There's a growing body of evidence that actually supports their use in a variety of settings. So they're applicable across different care settings and different populations. There are health economic benefits. So that's what we were talking about in the Peptamen study, where use of them actually saves money in healthcare costs down the road from not having to go to the emergency room as frequently, not having to get hospitalized as frequently, things like that. It can allow for more normalization of feeding because the individual that's using them actually can be receiving, similar ingredients to what you might be eating at the dinner table. And then lastly, psychosocial improvements, again, just from sort of feeling like you're not isolated from what everyone else is doing. Some of the more common indications for food based formulas that have been reported in the literature are that intolerance to the standard formulas, specifically with GI complaints of reflux, retching, vomiting, chronic diarrhea, or constipation. So, similar uses in that case to the peptide based formulas. Use in those who may have had feeding issues that was associated with developmental disabilities, GI disease, or conditions like neurologic impairments, and sometimes cancer. In addition, the real food-based formulas are indicated in those with severe or multiple food allergies where they can't find a formula potentially that they would tolerate because of an allergic reaction. And then lastly, patients who are on long-term feeding and who prefer formulas that have more real food ingredients is pretty common. So another benefit is that enteral formulas with real food ingredients often contain fruits and vegetables. And those ingredients actually promote the health of what's called the gut microbiome. So, to orient you, microbiome refers to a community of microorganisms, so things like bacteria, fungi, and viruses that inhabit a particular environment. In the context of human health, the gut microbiome is particularly important as it plays a crucial role in digestion, immune function, and overall well being. And then the microbiota describes particular microorganism populations that are found in a defined environment. So things like the oral or the gut microbiota. And what we've seen is that our gut microbiome actually prefers fruits and vegetables because the fiber and the phytonutrients provide this essential nourishment. So the more diverse the fruit and vegetable intake, the more diverse the gut microbiome and the better that it can support overall health. So Nestle offers 7 different formula options that contain real food ingredients for children. So on the far right, you'll see Complete Pediatric Original 1.0 and zero point 0.6. So those are the caloric densities that we talked about. And they contain real food ingredients that help support tolerance, and they tend to have a thinner consistency. So they can go through an NG tube, an NJ tube, or G&J tubes. And then the next one over is Complete Pediatric Original 1.5. So that's a 1.5 calorie per ml formula, so a higher caloric density. And it has a plant based option that has kind of a peach flavor. So, for any of you who have had oral supplements, it seems like the common ingredients is chocolate, vanilla, and strawberry. And if you don't like one of those, you're a little kind of out of luck. So, this offers a nice alternative for something by Mount that's more of a fruity kind of taste, if that's something you like better. And then we have Complete Pediatric Organic Blends. So this can help support tolerance. This is blenderized whole foods, and then also contains vitamins and minerals. It has no dairy or any of the other common food allergens. It's a bit thicker, so it's more the consistency of, say, like an applesauce type pouch. And so it's really intended only to go through larger tubes. So things like gastrostomy or jejunostomy tubes that are inserted directly into the stomach or small bowel. And then lastly, on the far right, you'll see Complete Pediatric Peptide. So that, much like that peptide-based class of formulas like Peptamen, contains, it's a plant-based peptide. So is partially broken down and then also does have real food ingredients and does contain some medium chain triglycerides as well to help support tolerance and absorption. And then for adults, you can see the similar products. So there's not a zero point 0.6 version of the original, but there is all of the products, and these are intended for people that are over age 14. And really, the only difference is the micronutrient content. So the vitamin and mineral content is higher, and then the protein and macronutrients tends to be a little bit higher, just to meet the needs of those who are older. So in conclusion, so nutrition related strategies for gastroparesis include modifications to an oral diet, so things like small frequent meals, low fat, low fiber, oral supplements, enteral nutrition, and parenteral nutrition. There are a number of categories of enteral formula that include standard enteral formula, peptide-based formulas, and real food-containing formulas. The latter can be beneficial for improving symptoms of feeding intolerance and in creating that positive changes to the gut microbiome. And then Peptamen is a peptide-based enteral formula that has been studied in over 24 different disease states, including gastroparesis, where results have shown improvements in GI intolerance as well as a decrease in the use of healthcare resources. So we're going to end up having more time for questions because I couldn't show you those videos, but I'm happy to take the questions now.
Robin, thank you so much. That was a great presentation. This is Jim, by the way. Hi.
Hi, Jim.
I'm going to read off a couple of questions that we got in the Q&A. Marie Jones wants to know, is this product taken through a tube or can it actually be taken by mouth?
I'm gonna go through all of them since I don't know which one she meant to. So Peptamen does come in unflavored and vanilla, so there are that options. What I will tell you though is because of the MCT oil, it tends to have a little bit of an aftertaste. So it's not the greatest option for oral, but you can do that. I find more that kids do that, mostly because I think a lot of times, depending on their age, they haven't tasted the variety of food that we as adults have, and so they tend to be more tolerant of things like that. The complete products, some of those, so like the complete 1.5 that has kind of that peach flavor. The complete organic blends, I actually think tastes a little bit like gazpacho because it has that sort of fruit and vegetable components to it. So you can always, I would always say that anything that comes flavored, you can try orally, and you can always doctor things up. So you can put the Peptamen in mixed with things, make more like a smoothie situation, like things like that, to sort of help hide some of the taste and the flavor, depending on what you prefer.
Okay, thank you. Susan asks, do the benefits of Peptamen extrapolate to other peptide formulas?
So yes and no. So what I would say is that how we talked about there are nuances to the different classes. So I'll go through some of them. So and I'll tell you the manufacturer because I can do that. So Abbott makes what's called Vital, or in kids it's called peptide. And so they have some of the same components where the protein is going to be broken down. There's going to be some version of medium chain triglycerides. What's going to differ is sort of the type of protein. So the Abbott products tend to be 70% whey and 30% casein, so they will do some curdling in the stomach. And then they have different amounts of MCT. So Peptamen has the highest amounts of MCT. Overall, parts of it are similar where the protein is broken down, they have MCT, things like that. But the more nuanced pieces are what differs. And so what I always say is that depending on what you're on, like if you're doing great on it, awesome. You found a formula that works for you. If you haven't, that's where it's worth kind of that, I think, discussion with your healthcare team about what other formulas are in that group that you're in. And is it beneficial to try a different brand of something? Or is it more beneficial to say, try a real food-based formula or a plant-based formula? There is also peptide-based formulas that are plant-based. Kate Farms is a brand that does that. There is not a lot of research on how quickly plant peptides that empty from the stomach. So most of the research has come into the casein and whey, which is where Peptamen has that whey protein because it has the fastest gastric emptying and then absorption in the small bowel. So hopefully that answered that question.
Did for me. Tammy wants to know if there's any advice on how to speak to your medical provider about getting onto
Yes.
this.
Yeah, that's a great question. I think this is my personal bias that all of us are sort of this is how I always viewed it. We're the architect of our own journey, right? So there is nothing stopping any of us from researching a product, looking into things, and then talking to the healthcare provider about what we want to do. I think the other thing that I would say is to ask them why. So if they're recommending something, I was never satisfied personally when people would say, "Oh, we'll just do this," because I want to know, well, why is it going? That's just my inherent curiosity. Like, well, why is something going to work? Why are you telling me to do that? And so I think it's okay to, I think, push back a little bit to say, well, why is it that your recommendation? Like, what is it about my anatomy that makes you tell me that you want to select X, Y, or Z? And also to, like I said, bring your own choices to say, hey, I heard about this product called Peptamen that has a type of protein that's supposed to be better for the stomach emptying or better in the small bowel, and have that discussion with your healthcare provider. I always viewed myself as the practitioner, as sort of the guide for the families that I would see, so that I could help explain, potentially what was going on in their body and then why the different components would work or wouldn't work in some cases. But ultimately, I think it's your decision, right? What you want to do. You're the architect of your own journey. So that's, hopefully that helps a little bit, but that's what I would say is be your own advocate.
Well, to kind of follow up on that, when a provider connects your weight to whether or not you have malnutrition, how do you talk about that? I mean, a lot of doctors will say, "Oh, you look healthy, so you must be fine."
Yes.
Yeah.
Okay, so there are very specific criteria for diagnosis of malnutrition, and they're not all weight related. So in kids, there is, I think it's a total of 6. So it's, if any of you have children or your caregivers that are on the call, I'm sure you've seen growth charts. Even if you don't have a child with gastroparesis, you've probably seen a growth chart. So for kids, there is weight gain criteria. So you might be totally looking fine and look like you're growing fine, but your growth chart has sort of gradually declined. So that's one way. Another way is actually intake in kids. So if your intake is less than 75% of what it should be for a period of time, and that period of time can vary, but I always would say 2 to 3 weeks, and not in the context of something else. So like if your intake is 50%, but you have a GI virus, that's very different than your intake has been less than 75% of what you need because you're constantly feeling symptoms of nausea and vomiting and fullness, right? So there's sort of nuance to that. Um, and then another thing is sort of also decline in what's called weight for age. So that's a comparison of your weight to your height. And everybody, I always say this, there's 100 percentiles for a reason. So it's okay to be growing at the 5th percentile if you're consistently growing at the 5th percentile, especially if genetically speaking, your parents are also small people. It's also okay to be the reverse. It's also okay to be growing at the 90th percentile if that's sort of the trend that you had. But changes and deviations from that matter. So, and sometimes you can't always see that visually, Jim, like you said. Like someone says, "Oh, you look great," but also maybe your growth chart is not only trending down, but your height ends up falling as well. So if we look at it from adult perspective, so there is weight loss percentages that are independent of where your weight started. So if you lost, say, I think it's 10%. I know the kid number is a little bit better, but I think it's if you lost, say, 10% in the course of 6 months. It doesn't matter where you started. That 10% in 6 months is an indicator. There's also other things in adults that are muscle loss, fat loss, and then something called grip strength, which is essentially like how hard can you squeeze something and grip something. And those are also indicators of malnutrition. So what I would say is to ensure that they're not just diagnosing based on the way you look, but they're using the diagnostic criteria that exist for malnutrition. And if you're not feeling like you're getting a good vibe from the doctor, I would always say ask if you can see a dietitian, because every dietitian that I've ever met knows how to diagnose malnutrition independent with using all of these parameters that are independent of just the way that you look.
Thank you. Yeah, these are tricky things,
Yeah,
and it requires requires a lot of communication with your physicians. That's true.
absolutely.
Um, Susan asks, but doesn't the gastric emptying rate of different formulas become irrelevant when patients are fed through like a jejunum tube? Which
Yes.
assume, yeah.
Yes. So yes, it does, but there's also nuance components of those formulas that still help you in the small bowel. So the whey protein, it not only empties more quickly from the stomach, but it's more efficiently absorbed in the small bowel. And so you end up being able to utilize more of it than compared to a casein-based formula. We talked a little bit about osmolality. So the higher caloric densities, for instance, the one benefit is that you need less of them to get through your day or to meet your calorie needs. But the drawback is that when you put some of those things into your small bowel, you end up with what's essentially water gets pulled into the small bowel to help dilute the formula because you want the concentration inside of your bowel and outside of your bowel to be the same. And so when that happens, that can trigger things like diarrhea. In some cases, because it's so limited water, it can act the opposite effect and it actually can cause some constipation. So yes, when you're in the small bowel, that does change what happens to the gastric emptying, but there's components of those formula that also do different things in the small intestine as well.
Thank you. Let's see. Matthew asks, are there any formulas being produced for people on the other end of the spectrum, people with rapid gastric emptying?
Good question. So I would say in that category, I would go towards more of the food-based, real food blended formulas. There is just inherent. I have never been able to explain the why behind this personally, but there's something that's just different about sort of inherently having food components in things that more mimic gastric emptying from if you were consuming food. And so they tend to, and they also tend to have more fiber in them, the real food formulas, because they have such a high fruit and vegetable content. So they will tend to empty a little bit slower from the fiber aspect too. So I would say to go down sort of a real food type formula if that's the issue you're experiencing.
Okay. And one more question, and this is a
hmm
pretty big umbrella question. Is it common for gastroparesis patients to be overweight with malnutrition?
So I would say that actually it is, in general, I think that there's a long-winded answer to this that I don't have time for.
Uh,
But what I would say is that I think it goes back to what you were saying earlier, Jim, about looking at the way someone looks. And there is sort of sometimes there's an assumption, I think, in the medical field that if you're overweight or obese or whatever term that you're wanting to use, that one, you're inherently unhealthy, which is not true because weight is not a behavior. So behaviors are things that you can actually change. So it's increasing physical activity. It is eating more fruits and vegetables. It is things like that, like doing positive things for what your blood pressure looks like, what your cholesterol level is, things like that. So weight is not a behavior that you can change. It, in most cases, is almost always genetically the number that you're going to be. This is a whole other lecture. But to sort of answer kind of what the question I think is that sometimes I would say that yes, is that it's a little bit harder because the bias in the medical field is that if you are overweight, you must inherently be eating enough and not malnourished. And so I think it's missed more commonly, I would say, in people who are overweight because that 10% weight loss might not be as visible on the outside as it is in someone who is smaller at baseline. So, but the criteria is not different. So the criteria for diagnosis of malnutrition doesn't differ depending on what the starting size you are is. So it is missed in the sense, I think, that there's just sort of a little bit of a bias to kind of that way you look. But
mm,
that doesn't mean that you're not experiencing those symptoms.
mm. You're knocking them out of the park, Robin.
Well, thank you. I try. And I think that goes too to just advocating for yourself. Like you know how you feel. You know where you started. You know that you don't have energy to get through your day because you can only consume 50% of what you need. So it's finding kind of advocating for all of that is advocating for yourself, but sometimes it's hard to do when you're feeling good, let alone when you're not feeling good. So
Yeah. A couple more questions came in, and we have a couple minutes. So,
yeah.
um, Daniela asks, what formula would you recommend for an infant who has autoimmune enteropathy?
Oh, so it depends on sort of what things you're trying to avoid. So the class of formula that we didn't talk about was elemental formulas. So those are formulas that are completely free amino acid based. So they have no allergens in them at all. Um, so that I would talk to a dietitian or doctor just about what they're trying to avoid in those scenarios. But there is another class. One of the formula names in that category is called alpha amino. And that is all totally free amino acids. And then there's a variety of formulas that fall into there too. We didn't talk about anything infant wise. Unfortunately, I stuck to kind of kids and adults, but that's a
Mhm.
whole those all these classes still exist in infant formulas as well.
Fantastic. Thank you.
hmm
Um, Last question in the Q&A here is from Yadira. She wants to know what seems to be more effective in helping with intolerance, whole food blends or peptide formulas? And can you
Yes.
still use whole food blends when you're feeding into the intestine?
Okay, so the second answer is yes. I'm going to do the second one first because it's a little easier. So the answer is yes. It does depend on the consistency, though, and the tube size. Any sort of nasal tube is only going to be, so we go by, it's called a French size, which is the diameter of the tube. And all of the different formulas have a recommended minimum French size, so minimum diameter, which is based on the thickness of the formula, essentially. So the thicker the formula, the larger the French size or the larger the tube diameter you need. So
Mhm.
something like the complete organic blends or complete pediatric organic blends is thick enough that you can't put it through an NG tube because it just won't flow. It'll clog the tube. But
Mhm.
there are some plant-based formulas that you can feed through an NJ tube or an NG tube, or in this case, you asked about small bowel, so NJ tube. And then
Mhm.
there are different types of tubes. So there's a gastrojejunostomy tube that is called, oh my gosh, I'm going to blank on it. I see I haven't talked about it in 6 months, and I'm going to blank on it. But there is a a G-Jet. That's what it's called. And that has actually the same diameter J port as a G port. So if it's a 12 or I don't think it comes in a 12, it's a 14 French G jet, then the diameter of the J tube is large enough that you can put a whole food formula in it. So some of it depends on really kind of talking with whoever the providers that put in the tube and what is the thickness and size of the tube, and then what formulas can go through there. So that's the second part. The first part of the answer is really more about severity of symptoms. So peptimin is still broken down from the dientripeptides that we talked about, so the 2 and 3 chain amino acids, and then how high the medium chain triglyceride content is, that it's really intended for more severe cases of either gastroparesis or just impaired bowel. The real food formulas are really kind of, you're not doing great on the standard. And so they're partially broken down in that peptide, but it's the complete peptide is not as broken down as the peptimin is. And they just offer a different direction. So if you're feeding into the small intestine and you're independent of the gastric emptying and the gastroparesis, personally, I'd probably go with a plant-based formula. If you're still having motility challenges even in the small bowel, then something like peptimin is more the direction that I would probably go. So think about it sort of is severity of symptoms. So the more severe symptoms would go sort of towards that peptide-based formula, and the more less severe the symptoms, then the real food formulas might be the option. But I also think trial and error is not the worst thing in the world. So if you know you're going to be on tube feeds for a long time and you really want a food-based formula, then try the food-based formula and see what happens and kind of go from there, especially if you're past the stomach.
Yeah, that's great advice. I like that. Uh, well, Robin, thank you so much. This is a great session. I learned a
Oh,
lot myself.
absolutely. Oh, good.
Jim, I'll step in for you real quick because I'm going to make you talk in a minute anyway. Let me see. Just try to move myself around here. So, thank you again, Robin, for being here. That was so informative, and we really appreciate everything that you shared with us. Sorry about the sound issue.
Oh, that's okay.
We do. If you have some time to stick around, there are a couple questions in the Q&A if you don't mind
Okay.
typing up some of those answers. And just thank you again. That was really great.
Absolutely. Thank you for inviting me.
So, barring any technical difficulties, going forward, I make no promises. We do have a panel discussion up next with some really great people. As we talk about gastroparesis and what's ahead, we brought in some voices from different parts of the system to share updates, their point of view on the future of gastroparesis care. And G-PACT's Jim Sliney is going to take it away. And our panelists, if you don't mind unmuting and coming off camera, I will try to fix everything on the back end.
Hey, everybody. One quick note before we start. For the attendees, if you go down to the menu at the bottom of the screen and you click on More, you can turn on closed captioning if you think that's helpful for you. Okay. So yeah, this is a very exciting part of the meeting here. Gastroparesis, as we all know, remains a complex and misunderstood condition. And we recently convened the 2026 Gastroparesis Summit bringing together patients, clinicians, researchers, industry to explore these different challenges from multiple perspectives. And that's what we're going to be talking about today. So I'll introduce our panel here. Um, our first panelist is Dr. Rick Pescator. He's a board certified emergency physician and the founder of Belly MD and a member of G-PACT's medical advisory board. There's Dr. Ali Navidi, a clinical psychologist and co-founder of GI Psychology. Tina Aswani Amprakash is a gastroparesis patient and CEO of the nonprofit Strategic Alliance for Intercultural Advocacy in GI. And Jacqueline Litzelman, the Director of Patient Marketing at Entera Medical and the owner of an amazing fish tank. So to make sure we get to hear from everybody, I'll just ask panelists to try to keep their responses to a minute or two. Okay. So let's begin with an important talk about how we understand gastroparesis as a disease. This is not so simple because understanding shapes everything from diagnosis to treatment. So I'm going to start with you, Dr. Pescator. So many many discussions about gastroparesis, they still focus primarily on gastric emptying. From your perspective, what important aspects of the disease does a focus on gastric emptying fail to capture?
That's a great question, and thanks so much for having me. I think we spoke about this on the last meeting and hit on such an important point. I think it was Dr. Pastrika from Mayo who really highlighted this and said it so well, that this is a spectrum of disease that is experienced in many different ways, and that experience is often lost when we minimize and narrow our focus to gastric emptying numbers. But fundamentally, the shared experience of misery around the disease is lost when we reduce it to simple numbers. Understanding the complexity of it, understanding the shared experience of nausea as a significant component, sort of universally, I think is an important way forward.
Thank you, Doctor. Anyone want to follow up on that? No, we'll throw to Dr. Navidi with a sort of follow-up question. So, Dr. Navidi, what emerging evidence suggests gastroparesis may involve broader mechanisms like neurological mechanisms, connective tissue, immune issues, systemic factors?
I apologize. I am experiencing some technical difficulties. Do you mind if you go to Tina first while things are loading up?
Yeah, sure thing. No problem.
I apologize. I'm sorry.
That's all right. Flexibility is our middle name. Tina, so many patients experience symptoms that don't always align with gastric emptying test results. How does that disconnect? How has it affected your experience while seeking care?
I think for me, for instance, when I first had a gastric emptying study, I asked my doctor, I asked my GI doctor, and I had to get a brand new motility GI doctor. Believe it or not, everything is sort of broken down in silos, even within specialties. And I remember saying to her, I was like, "Why would I need this? I'm not sure I understand because I also have Crohn's, I also have IBS-C. I live with an ostomy bag and no colon, no rectum, no terminal ileum. Can the gastric emptying speed actually be measured appropriately for me? Is this test even going to have any relevance for me?" And she was like, "Probably not, but we still need to establish some kind of baseline before we prescribe any medications." And I remember feeling really disheartened by that because I was like, I really don't feel like there's appropriate endpoints for somebody like me to get a gastric emptying test to validate a gastroparesis diagnosis. I had to jump through so many hoops and so many different kinds of tests. Truly, the gastric emptying test did not cut it for me. They were like, well, these numbers mean nothing to us. I'm like, yeah, because this is obviously going to run through me faster than the average person. So it's just there was a lot to this, and I think we really do need better testing options available upfront. I realize my situation's a bit unique, but also that gastroparesis does come with a lot of comorbidities that can lead to needing different forms of testing to get to a
Mm,
diagnosis.
mm, Thank you. Um, Dr. Navidi, you set up?
Yes.
All right,
Yes. Thank you.
cool. So I'll repeat that question I had for
Sure.
you. So what emerging evidence suggests that gastroparesis may involve broader mechanisms like neurological, connective tissue, immune, systemic factors?
So, as a disclaimer, I am just a humble GI psychologist. I'm not an academic. I'm not a researcher, but I am someone who's treated patients for many years, including patients with gastroparesis. And and as I've looked at the research over the years, just for my own understanding, my own basic understanding is that we're dealing with a heterogeneous syndrome, and that there's a lot of that gastroparesis is an endpoint for a lot of different mechanisms that are happening. Neuromuscular, autonomic, pyloric, post-viral. Like there's a lot of different things happening, and that as a GI psychologist, I was always brought in to just treat the symptoms. I never fully understood which mechanism might be happening, but very often we were able to help with the nausea, we're able to help with the pain, we're able to improve bloating. And sometimes the gastric emptying corrected itself. And I don't know if that was always through our work or if it was just happenstance. As we know, it can be quite variable. Um, so so I'd say that, just in my perspective, certain patients have really responded well, and I think those might be more affected by gut-brain mechanisms as well as other physiological mechanisms.
Hmm, Thank you. Um, so we're talking about some of these challenges to diagnosis and understanding the disease. These complexities show up in the diagnostic process. So, Dr. Pescatore, I'll throw to you. What are the most significant limitations of the diagnostic tools we're relying on right now?
Yeah, that's exactly it. When we can review just what we have already spoken about, and Tina, I think, hit the nail on the head when we talk about first the silos of medicine and the hyper specialization required to even seek out a diagnosis. But even when you do, number two, you encounter this algorithmic approach to medicine, which may not make sense, certainly is devoid of the answers that we're searching for. And what Tina said, number three here, which I think is most important, is that this isn't appropriate for someone like me. And then we jump exactly what Dr. Navidi said, which is the fundamental heterogeneity of this disorder. So understanding this fundamental heterogeneity, its existence within a hypersiloed medical system, but its existence cutting across those silos leads it very much in a diagnostic black hole. That being said, by pushing back on the historical approach, by pushing back on the numerical approach, the swallow this pill and we'll measure how fast your stomach kicks out approach, and leaning into this understanding, I think that that's where we make better diagnostic advances. Now, of course, we have better imaging. Of course, we're going to develop better blood tests over time. All of these things are the natural evolution of medicine. But here's where I think we drive everything forward. We listen to everything that was just said. We understand that this is a group of patients that have been cast out from the hyper-siloed medical system, and most importantly, have turned to each other in organizations just like this, in social media, and have shared their experiences, and in doing so, generated important hypotheses and important sets of data that can be analyzed to drive forward diagnostics. So I think that the future, the success, if we're going to have success, is by listening to Tina say that it has to be appropriate for someone like me. So therefore, understanding the fundamental individuality and heterogeneity of this disorder, and then leveraging new data and diagnostics to do so, that's how we move forward.
That's very encouraging. I like the sound of that. Well, Tina, since you were referenced here, what do you think are the biggest obstacles from your perspective for diagnosing?
Oh my God. I
Yeah.
will just say for me specifically, it took about 5 years to get a diagnosis. When, hindsight's always 2020, but like I feel like this gets mixed in with so many other GI diagnoses that it gets mixed up with others like IBS-C or other motility issues. And I think you mentioned connective tissue and all these other things that might cause dysmotility, that it's often not taken seriously, I feel. And I'm just gonna add the, woman of color perspective here as well. I just feel like, I remember one doctor, and this was a very paternalistic comment, but it hit home, and I do think I need to share this. Is just, he drew out an image and like a Venn diagram of how different things overlap with different conditions because I have so many conditions. And he's like, "Do you see how depression and anxiety overlap? I feel like you're overthinking this and that this is truly your depression and anxiety." And basically
Mhm.
completely invalidated my diagnosis. Now, the reason why I bring this up is that's an obstacle right there to getting a diagnosis when people don't believe you, when your own doctor doesn't believe you, when you have to go to several doctors just to finally get someone who believes you and then somebody who actually comes up with an option that's workable for you in terms of a diagnosis. I will also say some of the testing is grueling to get a diagnosis. I had one of the, antral, like, small intestinal, manometry tests, and they could not give me, proper sedation to put a tube down on the upper endoscopy down, and I was awake for the whole thing, other than some very light, painkillers. Just because the gastric emptying test couldn't figure this out. Also, doing small bowel series and other kinds of testing that requires gastrographin that's really disgusting to drink. I mean, I've drank a lot of things, a lot of different contrasts, but I asked the person, the radiologist doing the test, the person doing the test, "Have you ever tried this? Because I think you need to see what we go through." These are all barriers to getting a diagnosis. It takes a lot of grit for us to go through these procedures and tests, and a lot of grit to get to a diagnosis. Forget about the treatment part.
Yeah, it sure does. Um, well, while you were answering, I was thinking, gee, it would be great if we had a GI psychologist on the panel. So I thought, so Dr. Navidi, so how do clinicians better understand the role of like the gut-brain axis without dismissing the biological aspects of the
Right,
disease?
right. Tina, you set me up perfectly. Thank you. How do you avoid this invalidation? Because I think a lot of times people don't like complexity. Doctors don't want it. Patients don't want it. They want an answer that's simple and very straightforward. And the problem is the human body isn't simple and it isn't straightforward. And we do have a brain and we do have a gut. And there is a gut brain axis and it's a bi-directional communication. And that occurs in every single human. It's in all of us. And what we're saying is that for every patient, for every person, how our brain is operating is going to affect our gut, and how our gut is operating is going to affect our brain. And we can't avoid that. So it's rather than saying it's your depression or it's your anxiety, saying that it's all playing some role and there are things happening in your body that are very real and there's very real pain and there's very real symptoms. And we need to look at it holistically instead of from, I've heard before people talking, let's not include the brain in this. Good luck in doing that. I don't know how it's going to work out. Uh, but I think we know that for some patients, there's a bigger role that's playing. The gut brain axis is playing a bigger role, and in some patients, it's a smaller role. But it's always there. It's always there. Um,
Mm.
so I think we don't think of the brain as not part of the biological system. The brain is a part of this biological system that is complicated. And if we don't take it into account, then we're losing some levers, some very powerful levers for symptom management that I don't think anyone wants to throw out.
Thank you. Um, we're going to slide into treatment discussions here a little bit. So, because even once someone is diagnosed, the treatment options are quite limited. While you're here, Dr. Navidi, what do you think? Why has the therapeutic development in gastroparesis been so difficult?
Yeah, I think it's because of that diagnosis issue. I think that's a big part of it. I think there's a lot of different types of gastroparesis that are going to respond very differently to different types of treatments. And so, as an example, we have very little research on how gastroparesis is going to respond to gut brain therapies. And why we don't have that research, at first I was just blown away. I thought there was something wrong, I misclicked or I spelled something, but I couldn't find it. Whereas other disorders have a lot of research, years and years and years of research. And I think because it's been framed, because it's so hard to figure out, okay, what do we do? What type of gastroparesis is it? I I don't think people have bothered to just do the research to find out. Whereas with functional dyspepsia, we have a decent amount of research showing gut brain therapies can be helpful. But
Mm,
everything's been so siloed that we can't we haven't done it, or uh, it's just been unclear what we're studying if we're going to study. So
mm,
I think I think we're gonna get to a better understanding of how the of which variants of gastroparesis are gonna respond better and what aren't, but we need to start doing the research, and I think we also maybe need to include functional dyspepsia also in terms of doing research so we can help kinda suss things out. Um,
mhm,
so that's my hope that, we'll be able to identify in the future, um,
mhm,
potentially, like, what versions of gastroparesis maybe fit more into a disorder of gut-brain interaction, and which definitely don't. And we have some of that information, but we still have a lot more work to do.
mm. Thank you. Um, Dr. Pescatore, I'm going to throw over to you. What's the most frustrating gap between the patient need and what medicine and treatment options can currently offer?
Well, yeah, I mean, first off, great question because that's what it is, a giant gap, right? There's a chasm, a grand canyon between patients and providers when it comes to therapeutics around gut-brain disorders. And Dr. Navidi's so right. The fundamental heterogeneity of gastroparesis has been a handicap in its therapeutic. You cannot put 100 people with 100 different diseases into the same trial and think that the same thing you're trying across them is going to lead to a good outcome. And so what has led to the failure of advancements is a perfect storm of the fundamental heterogeneity of the disease, the hypersiloed medical system, which has left these disorders without somebody to own them and love them and want to drive forward research for them. And then on top of all that, a failure of the medical community to drive forward an evidence-based medicine curriculum that holds that nuance and complexity. It's a big problem, right? You know, this problem is a symptom of many, many underlying issues, including a medical system that just has not been built to hold the complexity of these conditions. And so what you end up having is few people even taking a bite at the apple, and those who do take a bite of the apple are doing it kind of without the true understanding and passion behind clinician guided therapy. That being said, I am eager and optimistic for the future. Dr. Navidi said several times it's about which types of patients, which groups, which subgroup, which phenotype, which subcharacterization, and so what we get as an understanding that the future will be driven by subtyping, will be driven by understanding shared phenotypes, will be driven very much by involvement. And so the question as to how do we fill the gap between patients and providers and therapeutics, the answer is G-PACT. The answer is organizations like this that span that gap and bring interest, research, passion, funding, and focus, and a better understanding of who is suffering from these conditions and how it needs to be approached. If you tell every gastroparesis patient on this panel that we're going to increase, improve their gastric emptying time by a certain amount of milliseconds, okay,
Mhm.
but they're going to be much more interested if they're told we're going to substantially decrease your nausea or vomiting or bowel discomfort, a patient-oriented outcome. We call it POO, patient-oriented outcomes, not DO, disease-oriented outcomes. And for gastroparesis, I think POO is what's in order.
Who has always been at the center of these conversations. So thank you. Um, to the attendees, by the way, you've heard the term heterogeneous many times now. I just want to clarify, this means it's made up of elements and ingredients that aren't the same. Homogeneous means everything's the same. Heterogeneous means all the elements are kind of different. Jacqueline, I'm going to throw to you. So from your perspective in industry, what factors determine whether a disease area like gastroparesis becomes a priority for therapeutic development?
Yeah, Jim, thanks so much for having me. I think from an industry perspective, a disease becomes a priority really when there's three things: the science, the patient need, and then the business realities all line up. And so when our leadership looked at gastroparesis and, made the decision to invest in Intera Medical back in 2022, they really saw a gap. And I think, Rick just mentioned this, right? On one hand, patients were telling us how frustrated they were with limited treatment options. But on the other hand, there were thousands of patients sharing how life-changing Intera therapy had been for them. They were getting back to school, they were getting back to work, their everyday life. And so that contrast really made the opportunity very clear. There was a real need here. The impact of Intera therapy was real. And so the space really deserved more investment. And so at that point, the focus really became, how do we do better here? And that meant bringing in new technology, pushing clinical science forward, and really showing up for gastroparesis patients in a much more intentional way.
Hmm. Thank you. Tina, I'm going to come back to you here now. Of the treatments that are available, what's the hole in the patient experience that's not being addressed primarily?
Honestly, and I'll give you my experiences, I'm on domperidone, which is not even available or approved in the United States. I have to jump through hoops to either get it from Canada or have family get it for me from India. That is not a way for a patient to live, and that's the medication that works best for me. I've tried others. There's been significant side effects with some of the medications that I've had to take, including Reglan and some of the others. So to deal with the nausea. So I am jumping over hoops to get access to this medication that's not approved in the United States. And when I ask questions about why it's not approved, I don't get clear answers. So I still feel like there needs to be significant drug development in the United States or more compassionate use considerations. I understand some of these are under compassionate use for some folks, but still not that easily available and still really expensive for patients. I've really struggled with this, and I really feel that there needs to be more awareness, attention on this disease, and attention on the fact that we don't have good medicinal options. This is not as simple as just change your diet or, take enteral nutrition of some kind to fix this. And I know many of us have had to have feeding tubes and have had to be on different forms of medical nutrition, but it's not often the fix for this. So I really would like to see more and more investment into priorities related to treating gastroparesis. I think that starts with, what Dr. Pescatore was saying. It starts with G-PACT. It starts with the awareness, the advocacy, the Hill days, and sort of making it known to drug companies how badly we need this.
Hmm. Well, while you have the speaking stick, let me ask you then about research a little bit. Um, if you had the microphone in a room full of researchers, what's the most important thing you would want to tell them?
I think it would be that we don't have enough medicinal options or medical options to treat this, and certainly ones that can be covered by insurance in this country. And the same thing goes for medical nutrition. A lot of this is out of our pocket; it's not covered. And I've really struggled with that piece of things is just how expensive this disease gets because there aren't good treatment options for us, and that we have to use things, at high expense rates for ourselves and our families.
Mm, thank you. So, I'm going to throw over to you, Dr. Navidi. So, if we're talking about putting together all this research information to drive forward um, treatment development, if you could create an ideal data sharing plan to accelerate research data, what might that look like? Do you think?
Yeah. Well, first off, I love that Dr. Pescatore introduced me to the term poo, because in that moment, I realized I've been dealing with poo all my life, all my career. That's what gets sent to us in terms of GI psychologists, because regardless of the diagnosis, we're working with those patient. What's important for them? If they come in and nausea is the thing that's just crippling them, then that's what we're working on. If it's pain, if it's bloating, if it's vomiting, that's our focus. So I never realized it, but I've been working in poo all my career. Now, in terms of research, um, you know, I would love to partner with people who are doing research to let's start looking at where the gut brain therapies can help, because there's been almost no research there, and we know in other areas of GI they can be tremendously effective. I'd love to see some versions of gastroparesis alongside functional dyspepsia being looked at, and including gut brain therapies in that mix, because I really would love to be able to tell GI patients this version, this subtype of gastroparesis that you have, it responds really well to gut brain therapy, and we can help you with your nausea, or we can help you with your pain. That would be my kind of dream, to be able to answer that question for patients.
Mm. Well, Jacqueline, I'm curious, what kinds of to reach this goal of better pooled data, what kind of partnerships between clinicians and patient groups, nonprofits, and industry are the most effective in accelerating research and treatment development? Like, what do you see that model looking like?
Yeah, I think partnerships like this are so critical. In a space where there is this complexity, no one group alone can really solve the gap. And so gastroparesis is really complex. It's a nonlinear journey. Symptoms are fluctuating and the burden is often invisible. And so with that, traditional endpoints don't always capture what the patients care about most, right? And so when we can bring together clinicians, patient groups, and industry and really level set on, what does this look like in the real world for both the patient and the clinician? And what does meaningful impact and improvement really mean? When we can co-design these studies together, communicate and invest together, we can really end up with research, I think, that's going to move faster, and then treatments that are far more meaningful for the patients.
Mm, thank you. Um, Dr. Pescator, when we're looking at this variability between diagnostic criteria, how is this affecting clinical trial design and how we are able to generate reliable results? Is there more gaps and chasms that we have to cross here?
Yeah, kind of exactly. Clinical trials obviously need to be designed for what's driving them. So if the clinical trial is being driven by an NIH grant and it's for academic pursuit, then the endpoint can probably be more liberally approached than industry needing to meet FDA endpoints. But with recent evolution around the FDA, recent evolution around better understanding in gut brain disease, I am hopeful we will see improvement. It really comes back to those outcomes again, always do versus poo. And it's easy to pick disease oriented outcomes. Well, the reason we don't have domperidone in the United States is because people walk around chanting around QT prolongation, which is a disease oriented outcome. It's not a patient oriented outcome. The incidence of torsade de pointe from domperidone is about half the incidence of a pheochromocytoma. It's so rare, but we get so concerned about these things and we get spun up. But I think that Jacqueline's 100% right that no one entity is going to be able to tackle this, except to say that everybody working together may. And a few months ago, the government's put together their digital health environment, which has brought together a number of diagnostic and therapeutic companies in this space to bring patient data into a more centralized understanding. Now, there has to be the forever trade-off in understanding of privacy versus advancement. We can never trample patient privacy in the name of anything, even if it's advancement. But by harnessing all this shared data, and there are efforts to begin to bring this together, I think that that's where we'll see advancement. And then to just kind of finish this of we haven't seen advancement and why it very much goes back to what Tina said at the very beginning, is that she's a female of color who's walking in to get care, and she's historically been cast out by a system, again, not built for her. But as again the system is changing, we are at the precipice of direct to consumer care, right? Everything's changing. Where innovation happens, where change happens, will continue to be influenced by the almighty dollar. But fortunately, the influence of that dollar will now be more driven by the consumer, which is obviously everybody here.
Thank you. Tina, you had your hand up. Did you want to jump in on something?
Yeah, no, I think you've made some very important points, Dr. Pescatore, too. I think, and Sam would know more about this, but like one thing that I feel like has not been done enough in the gastroparesis community is also just involvement of patients in the clinical trial protocols. I haven't seen a lot of that in GP, and it's been disappointing because I also think that yes, however industry approaches this with FDA, it's important, but I don't see enough patient input into what's actually feasible for us and what's actually friendly for us because this is a challenging enough disease that we can't just automatically be considered for a placebo or automatically be considered for something without a comparator agent. So I did want to just highlight that too with clinical trial protocols. I really would like to see more patient involvement and engagement such that we can help define this a little bit better. It is something that I feel like I've been involved in many other areas, and we're trying to make strides in those areas, but it's just not enough in gastroparesis.
Yeah. I mean, speaking from my own experience, I worked as a clinical trial coordinator for about 15 years. And what was going wrong was that what was going right is great protocols are being developed, but the part they missed was that they didn't include patients in the development part. So they were asking for unrealistic things that patients weren't going to be able to perform. And so yeah, I'm a fan of seeing patients involved in the early stages of protocol development. Dr. Navidi, you wanted to jump in?
Yeah, I just remembered an example of, I think, what might also work here. So a few years ago, we partnered, my organization, GI Psychology, partnered with the Crohn's and Colitis Foundation, and in that partnership, we created a novel group therapy for IBD, so inflammatory bowel disease. The only way we were able to do that, because notoriously groups are very hard to fill. And so we wouldn't have been able to justify that expense and those hours and hours of time to develop that protocol if we didn't have the support of this other organization, the Crohn's and Colitis Foundation, to bring attention to it and to let patients know. And because of that, now we've run a number of cohorts through that protocol. The results are looking really good. And so that's something that would not have moved forward without organizational partnerships.
Mm, thank you. Yeah, earlier this month, G-PACT convened the Gastroparesis Summit. The idea, I mentioned this earlier, the idea was to bring the stakeholders from all across the terrain into one place and discuss things like the persistent barriers and care and research and the like. Um, and there'll be some interesting reports coming out of this that we'll be able to share with everyone. But we're developing something called the Gastroparesis Advocacy Network, which is essentially dividing into 3 teams that are going to try our best within a 6-month period to address certain issues that rose to the top. And we can talk about that another time. But uh, in the spirit of that collective gathering of minds, I want to ask an open question to the panel. So if the field were to focus on one priority in the next 3 to 5 years, that would meaningfully change outcomes for patients, what do you think that would look like? Anyone can take this. Jacqueline?
Yeah, Jim, I'm happy to jump in here. So I think, if the field could focus on one priority, it's got to be, making patients access to care and therapy easier and better. Like Tina said, there's too much delay in diagnosis. There's long waits for specialists. These patients are super sick, and the inconsistent care and treatment pathways really is a big burden. In addition to that, there's this stigma where they're not being taken seriously when they show up at the doctor. So I think that needs to be a focus. But that being said, we also need to set the clinicians up with the tools and the training and the confidence that they need to diagnose and manage these complex patients. And I think one of the challenges that hopefully can be addressed quickly here is this fee-for-service system that disproportionately rewards procedures over the time-intensive management of these complex patients. And so until we can really solve that, the physicians are going to continue to be stretched thin. But if we can evolve these payment models, I think there's a real opportunity for the patients to be supported in a more balanced, patient-centered way.
Thank
I just want to echo that because I think that absolutely right. Awareness, education on all sides of this, right? Patients need to educate each other. Clinicians need to get education about what this is, what can be done about it, and the reimbursement reality is a significant one. The lack of procedurality around this has historically sent clinicians in the opposite direction, and the time pressures have been killer. I think again, I'm an optimist, I guess. At the beginning of this year, the feds put together some new reimbursement around chronic pain management in patients with gut brain disorders, which to the savvy clinician should enable them to offer additional services. And I think that we really are at the very beginning of people beginning to understand what the heck this is, and that it's real, and that there's a lot to understand and do, and it just wouldn't be happening without things like this. So
We've got just a few minutes left, and we have some questions in the Q&A. So I'm just going to throw to some of these. And again, this is for the whole panel to respond to. Um, what are your thoughts on trying a non-invasive vagal nerve stimulator to reduce nausea and other GP symptoms?
yeah, we used that. Oh, I'm sorry, I stepped on you, Tina.
No. That's okay. Go ahead.
My perspective is I'm an emergency physician to give the lead here, but there are some efforts throughout the country, non-opioid focused efforts for pain and nausea management throughout the country. The focus here is actually in northern New Jersey, and they've tried and they've successfully implemented vagal nerve stimulation as well as acupuncture for this. Generally, their results have been mildly underwhelming, but still at least a little whelming.
Tina?
Yeah. So one of the things my GI motility specialist recommended early on, and it took me a really long time to find her, is she said there's some research on electroacupuncture. So Dr. Pescatore already started to mention that. I actually have been doing that for the last almost 7 years. And I find it extremely helpful for the motility concerns and even for the nausea. So it is something that I highly recommend. You just have to find somebody who's really good, and it can get expensive unless you can find a way to get it covered.
I think,
So
yeah.
yeah.
Oh, sorry, Tina. I stepped in.
Sorry. I was just gonna say, like, I that's what I know that she does do work on the vagus nerve. My acupuncturist, and I do believe that's a form of vagal nerve stimulation that she's been working on. Sorry.
Ah, no problem. I think there is some research looking at this non-invasive vagal nerve stimulation, um, and I think it's a very safe thing to try. Like there isn't much downside other than the initial cost of the device. There isn't too much risk in terms of just trying it. And then at the very, very least, there are patients that will at least see reductions in anxiety, and then some will actually see physiologic improvement.
Well, here we are at 12:59, and I think I'm going to throw back to our president, Sam. I want to thank everybody for being on this panel. This is really good discussion, and I've got a lot to think about. Took a ton of notes. So thank you all very much for being a part of this. Really appreciate it.
Yes, and I'll echo as a thank you. If any of our providers or panelists want to or are able to stay on, we did get some questions in the chat to answer. If not, we're keeping track of all the questions, so we will get answers to those and get them out to participants. So right now, we are stepping into our intermission because we all, we all need to get the wiggles out, and it's a long day of sitting. So I am super, super excited to share. We've got Jamie on the screen now. She is a yoga teacher who helps people connect with their bodies through breath and gentle movement. So stick around, take some time to center yourself. I sure know that I need it today. And our sessions will resume again at 1:15. So take it away, Jamie.
Awesome. Thanks, Samantha. Such an honor to be here. Kind of beautiful synchronicity that we get to end on the vagus nerve because that's a lot of what we're going to tap into with the breath. We're not going to use a soundtrack. We're just going to use the sound of our breath. So this is a moment as well with these 15 minutes. If you need to go to the bathroom, if you need to get a drink of water, do what you need to do. I'm just here as a guide. I will suggest to have a pillow nearby, and we are going to start standing. If you'd like to stay in your seat, that's also totally fine. You can do everything from there. Any pillow will work, and I'm just going to keep her back here. So we've been given a lot of information today, a lot to process in the brain, a lot that probably comes up emotionally in our bodies. So we're just going to start by shaking our hands, whether you're standing or sitting, starting to deepen the breath in through the nose, expanding the belly, and sigh it out. Taking a couple breaths like that, maybe engaging more of the arms, getting into the shoulders, whatever feels comfortable for you is gentle movement. Again, focusing on those deep inhales through the nose and exhaling through the mouth. Maybe the torso moves a little bit. Maybe the knees start to wiggle. And the best way to get into our parasympathetic that nervous system, that rest and digest, is through deepening the breath. Another hack is through, again, deep inhale and make some noise or sigh it out. A hum also works. One more time, inhale, exhale. On the next inhale, we're going to keep the feet about hip width distance apart. Bend the knees, arms rise. Maybe the head looks towards the hands. Exhale, cactus the shoulders. Again, you can do this from your seat as well. Inhale, rise. And then a big exhale as we cactus. One more in. Exhale, maybe shake it on the way out. And we'll take a moment still standing, placing a hand on the belly, a hand on the heart. And closing down the eyes, if you're still craving some movement, maybe some small circles where your hands lay on the body. And taking some time without changing your breath to notice where it's sitting in your body. With any thoughts, with any aches, with any pains that come up, instead of thinking deeper into it, can you take a deep inhale into where you feel it? Maybe it's an intrusive thought in the mind, breathing into the back of the skull. Maybe it's a pain in the hip or in the stomach. And on the exhale, let it go. Knowing our pain doesn't just go away, but knowing that when we calm the mind, going back to that mind-body connection, what can shift? Noticing it all with curiosity. One more deep breath in and exhale, let it go. Slowly letting the arms come down by your side, wiggling the fingertips, maybe wiggling the toes. And if you're not already seated, we'll gently blink the eyes open and find our seat. And what we'll do is sit with, you can't see my feet, but my feet are flat on the floor and my hips and my glutes are at the edge of the chair. So my feet can be flat and I have a 90-degree angle here. This is where the pillow may come in handy to put it behind your back if you're looking for some extra support. So just getting comfy here, maybe again, wiggling out the feet, maybe the the knees circle in a bit, maybe the torso circles, and just noticing on your inhales as you start to deepen, letting the spine get a little bit longer, feeling the tailbone pushing into the chair, the floor, the couch, and the top of the head going towards the top of the room. And on the exhale, getting a little bit comfier, maybe dropping some tension in the hips or some tension in the mind. We'll take 2 more breaths like this. Inhale, spine lengthens. Exhale, release something that's coming up for you. One last deep breath in here and let it go. Blinking the eyes open if they were closed. You're also welcome to keep the eyes closed during this practice. We'll be taking some gentle rounds of movement. So we'll start with the spine, letting the hands come on the top of the thighs. We'll inhale, the heels of the hand come toward the hips. We arch the back, and then we exhale, round the spine. The fingertips come towards the knees, maybe even grasping onto the knees and getting some wiggles here. Taking a few rounds like this. Inhale, arch the spine, heels of hand, towards the hips. Exhale, arching the spine the other way, hands towards the knees. On the next few rounds of breath here, options to maybe wiggle that torso, finding your own unique movements here. And really just being gentle, notice what you need in your body, what works best for you today. These are all options. If the answer is stillness, then the answer is stillness. Taking one last inhale here and exhale, coming back, straightening our spine. Maybe notice any other wiggles that we want to get out as we move towards the neck. And the way we're going to start with the neck is we're going to extend the arms out long. Not having much tension here, so maybe tense for the first time, shoulders to ears, all the fingertips out. Exhale, let it go. Finding some normalcy, finding some fingertip movements here. And then we're going to, almost like we're holding a basketball in our hands, we're going to take one arm, inhale, turn it to the back of the room, and exhale, turn it the other way. And then let's try that with the other arm. Inhale towards the back, exhale towards the front. Now we're going to do these opposite movements. Inhale, one arm towards the back, one the front, and exhale. You can do one arm at a time if that feels good. It might be nice to get the shoulders more involved as you get into the movement. And what I suggest here is to let the slowness of your breath guide the slowness of your movement. It doesn't matter how you look. It matters how you are breathing through the body and what the body is sharing with you. What information can you be curious with? Where do you need to adjust? Where do you need to deepen? Taking one last full round of breath. Inhale and exhale, shake it out. Let it go. How does that help with the neck? Because it loosens us all up in here to get deeper into the neck. So we'll let the hands come onto the thighs, maybe noticing if you have any tension in that lower body, just adjusting it and slapping it out. Maybe even just taking a snap down the legs. Beautiful. Okay, now we'll move towards the neck. We'll take an inhale, looking over our left shoulder. Exhale, letting the chin drop. This one doesn't go far for me today. Inhale, rising just a little bit, maybe an inch. And exhale, starting to move that chin through the collarbone. Letting the exhale just deepen this here. As your chin reaches the middle of your chest, you'll take another inhale. Exhale as you move towards the other collarbone, towards that right side. Going slow, again, noticing where you need to adjust and where you need to deepen. Taking an inhale just to rise, let the chin go towards the top of the room. Exhale, lower the chin down. Inhale to rise one last time. And exhale, letting the chin go all the way back, circling towards the other side. And noticing what comes up for you here. And can you just take a deep breath in and an exhale, moving all the way towards the other side. And maybe finding a full neck roll if that feels good. Otherwise, just finding your own pace as you let the chin guide the neck movement. Maybe staying and breathing in spots that feel particularly sticky, that need some extra blood flow, that needs some extra air. Letting out a deep sigh also helps to create space of movement. And wherever you are, we'll take another 2 rounds of breath, eventually bringing our head back to center. Taking a deep breath in together. And an exhale, let it go. We'll let the arms rise, moving into a gentle twist all the way towards the top of the room. The right hand will come to the back, whether it finds the back of that chair, your back, or maybe even just that hip. And then we'll slowly move towards the other side, letting the left hand come towards the right knee. And really here, you want to feel your shoulder blades and your shoulders extending, your chest being brought forward. Taking an inhale here and an exhale. This doesn't need to be deep to be effective. One last deep inhale here and exhale, let it go. Slowly releasing that left hand, letting your body slowly come back to center. Taking a collective breath in here and exhale, let it go. Inhale, the arms rise. And we'll do the same thing on the other side. Again, finding where that left arm feels comfortable, letting the right hand come towards the knee, and really focusing on the expansion of the shoulder blades towards the opposite side of the room. Taking a deep inhale here and exhale. 2 more like that. Inhale. One last one. Letting your exhale slowly bring you back to center. And for our last few moments, any other movements that call to you, I recommend taking. Maybe it's just kind of massaging out the legs, going down the body. Again, staying in any part that feels sticky, that feels like it needs more love, that maybe you can just grab and take a deep breath in and exhale. There's no rush to move, there's no rush to do anything. The slowness is where the magic happens. The stillness is where the magic happens. So again, finding any spots that call to you, any last movements before we take a moment to replant the feet, feel our pelvic tilt. Maybe the spine gets a little bit taller. And we'll take a few remaining breaths here together. Maybe noticing what feels different from when we started to where we are now. That's not to notice how much more work do I have to do, how much pain does my body feel. It's to notice where was there expansion and where could there be more expansion in the future. Anything in the future, the way to deal with it now is breathing in the present, breathing into the thought, breathing into the feeling. Taking a few rounds of breath to do this together, wherever this sits in our individual bodies, through the nose, deepening the belly, the rib cage, the chest, the back of the heart. Let it go. Inhale, maybe taking an extra sip at the top. And exhale. Inhale and exhale. Nothing to do, everything to notice. Letting your eyes slowly open if they were previously closed. We'll take one final movement and breath together, letting the arms come out by our sides. Inhaling, letting them rise. Exhaling, bringing hands to heart center. Thank you so much, and I hope you all enjoy the rest of your conference today.
Thank you so much, Jamie. That was wonderful. I definitely needed that. Um, so I don't know about all of you, but I definitely feel so much more grounded and so much more centered. I needed to be reminded to breathe and get my shoulders out of my ears because I'm stressed. So our next speaker today is Kara Corey, and I am so excited that she's here. I've gotten to know Kara personally. Oh, I'm actually going to get emotional. Sorry, Kara. I've gotten to know her personally over the last few years, and I can tell you without a shadow of a doubt that this woman has changed my life. She is a registered dietitian with almost 20 years of experience, and she blends medical nutrition therapy with mindset behavior principles to help clients move beyond restrictive dieting, food fears, and all or nothing thinking. So, Kara, if you're ready to unmute and come on camera, we'll get started.
Thank you, Sam. Geez, you're going to make me emotional too. You know, I'm a big mush over here. I'm so honored to be here today and to be speaking to all of you. I am a registered dietitian, and I think my talk today hope comes to you from a bit of a different lens, not as much clinical focused, which maybe some of you are very used to in your dietitian interactions, but more so my own personal experience with living very close with someone with chronic medical conditions. That showed me a whole different lens of what it's like to really be someone living with a chronic medical condition. something a bit more invisible that not everyone sees, and just how much it impacts the entirety of your life beyond just your food choices. So while you can mention you're someone with gastroparesis, a lot of people can be like, okay, that's a GI disorder of some sort, right? People don't often really think about how much it really impacts you as a person, your overall life, your quality of life, your confidence, the social ease that comes with not having to think about everything you're eating and what your body's allowing you to do in the day. So I want to focus today's presentation a bit more on that side of things. I'll share my screen here for some slides as well. Everyone can see that okay? Hope. So I really want to talk a bit more about that side of things today and just like really how to gain a sense of confidence back within yourself and with your food choices. I don't want to sit here and tell y'all what you should eat or not eat, because I'm pretty sure you've probably heard that before. Hopefully, your experience with dietitians has been good, but I know sometimes it's not, especially with medical nutrition therapy. We can be very used to just seeing a diagnosis and handing someone, here is your diet therapy you should do. And really, I think it's so critical, especially with chronic conditions, something like gastroparesis, is to kind of blend together, the nutrition ideas that we need to consider, but also our mental health and well being and how it impacts the total person. So I really like to come at it from a total person approach. So when we talk about gastroparesis, this condition, as you guys know, it impacts so much more than food, right? It impacts your eating. You are no longer someone that can just get up every day and not have to think about every food choice. And with that, this can really impact your level of confidence. I'm not sure if you've ever thought about it like that before or not, but it can definitely limit your sense of self, your feeling of connection, maybe with other people, become a very isolating condition, right? It can definitely impact your spontaneity in your life, how quickly you can just pick up and go, and if you can travel, or if you can just go head out and have dinner plans with your friends tonight. So that definitely really is something that impacts the overall person. Those everyday moments that maybe the average person takes advantage of, with how much thinking about everything you eat and how it impacts you could potentially change the trajectory of your day. So it really can make you question your body. It can make you almost feel not like yourself, right? Like it can make you almost feel like you don't have control over your body. It can make you, in a sense, kind of make your life feel smaller. And I say that, and I think it's important to name that in terms of saying it could potentially make your life feel smaller, not because it should, but because of the impacts that having a condition like this can really have on you. It can really make you think that um, you no longer have the freedom you once had. It can definitely just kind of change that sense of ease you maybe once had in the world. And it impacts us in a very real way, right? And especially for any of you on this call that are maybe someone who previously, or maybe you currently are, that like perfectionist type person. You're someone who's very disciplined and very driven. And, maybe you relate to being that person that if you need to do something, you do it and it works out. Or if you're told to do something, you do it to a T. And so we can kind of get very programmed in the identity, if you will, to think, well, if I'm doing all the right things, then my body should react accordingly. And we just know that's not always the case with gastroparesis. So this next slide talks about awareness before change. So one of the biggest things that I like to teach is really just becoming so super aware of yourself, which many of you probably already are. I find that anyone with a chronic health condition is usually my most self-aware individual that I work with, because you guys are kind of forced into that. You're forced into having to really think about every food choice and how it impacts you, right? Like every decision you make during the day could maybe turn turn into a flare, or maybe it could all go well. You never really know, right? You can plan everything accordingly and it just doesn't always go as you had hoped. So awareness is such a big thing to really consider here. So you can't fix anything if you're not aware of it. You can't improve anything that you're not aware of. So really being honest with ourselves in terms of who we are, some of the thoughts that we're having about our condition, how we're managing our condition, um, and those thoughts that come with this condition. So I do want to name them and kind of talk about this because these aren't just symptoms, right? These are real emotions. And it's very valid that you feel these emotions. And I don't mean that you feel them and then they go away because you've had gastroparesis for 20 years. It doesn't work like that. It's not linear like that. But things like fear, right? Fear, grief, frustration, isolation, and shame. Are these any feelings that really resonate with you? I think they're very common with any medical condition, but I do think it's important to name them and kind of recognize when they're coming into your day, when they're coming into your mind, and really what it's saying to you. Things like fear can really come about like, what if I eat this and it makes me feel worse, right? So we can get a lot of fears created around food. Maybe we already had fears around food to begin with, right? Maybe this isn't the only thing you're struggling with. And then all of a sudden now you have to really think about every morsel of food and if it could potentially impact you negatively. And well, what if you're not at home either? And then you're dealing with those symptoms, right? So fear is a very valid emotion and response. What may happen after? The other one here is grief. If you felt any sense of grief, when you miss that life that felt easy, when you miss not having to worry about every single piece of food you put in your mouth, when you miss not having to worry about what was going to come afterwards, how easy things maybe used to feel, or maybe just grieving the life you once had, um, is very valid. And so looking to frustration may sound something to you like, why is this so hard all the time? For us who, are, someone who sets out to do what we're supposed to do and it still is hard and it maybe doesn't agree with our body, even though we did what we were told or we did the medical nutrition therapy that we thought was appropriate or we did what worked for us yesterday, right? This food always goes over fine for me. All of a sudden it doesn't. Why is this so freaking hard? Okay, the next feeling here is isolation. No one understands this. This is a very isolating condition. This is where you can feel very isolated and closed off. We definitely know with gastroparesis that there is going to be an increase in depression and anxiety. So these are things that we definitely want to become very aware of our emotions. And it's very easy to feel like no one understands you because no one's living in your body. Even your peers that also have gastroparesis, everyone's experience is going to be different. So it can become very isolating. Then maybe also some shame. Maybe shame is another feeling that comes about for you. Like, why can't I handle this better? Maybe you're kind of going introspective on it and feeling like I'm doing what am supposed to be doing. Why can't I get this right? Why am I still having flare ups? Or why are things still not going right for me? And I think for many people, those feelings are tied to food. Sometimes it's bigger picture, but overall, these are valid feelings. I want to make that very clear. I want you to understand these are not irrational feelings to have. These are very understandable within gastroparesis. And so a very simple tool with all of this, just I like to keep like little simple tools here with each of these things is really thinking about what am I actually feeling right now with this emotion? Really taking pause and just being able to ask yourself what you're feeling in that moment versus not what should I be feeling, not do I wish I was feeling this, but what are you actually feeling right now? And kind of being able to name it and just come from a place of less judgment. Okay. Because I think a lot of times we don't want to be self aware with some of these emotions because we can feel our own self judgment that we shouldn't be feeling this way anymore. And so I just want to be really clear with that your experience, your emotions, they are valid. You're never overreacting. experiences and feelings that can come up at any time. And being aware is not a sign of weakness. This is where some support can come in and hopefully help you. So just to really be clear on, those responses are not dramatic for you. Those are very, very valid. So those emotions are going to be expected within this condition. Um, and I think it's important to say too, like with your experience, um, you don't have to earn compassion by being at your absolute worst. I think sometimes we worry about getting support or compassion from others when we're, in the hospital or at our lowest and doing our worst. And that's not the case. You don't earn compassion. I think a lot of people with GI conditions, especially, we try to just act like everything's fine, or maybe minimize our symptoms, minimize our lifestyle, what we're really dealing with, to make other people comfortable is very common. But that's really hard. And I will never tell you how you need to act or how you need to show up or how you need to explain this condition to others. But more so, I want you to think about what's being talked about internally in your own thought process, how you're naming things, how you're labeling your own emotions that are attached to this, and just be really aware of it, and be gentle with yourself when it comes to this. So it's something to really think about. A lot of times we try to label a hard day or hard experiences, if you will, into proof that we're failing. So maybe for you that feels like, well, I messed up. My symptoms flare. I should have handled this better. Why is food feeling hard again? Why am I still struggling with this? I think it's really important to come back to the fact that those hard days, those challenging days, they don't ever mean you're broken. It doesn't even mean you're doing something incorrectly or wrong. And inconsistency is exhausting, right? I think for the average American who is healthy, if you will, and doesn't struggle with medical conditions, consistency is really challenging for the average person. And then when you throw in something like gastroparesis that can be really unpredictable, um, that inconsistency can be so tiring for you as an individual. And when your body then feels unpredictable, it kind of makes sense where with this condition, your confidence could be quite shaken from that. It could be hard to show up as a confident individual because you could really quickly lose that trust within yourself, feeling kind of putting it back on yourself, like, why can't I get this together? So the problem here that I'm alluding to is that self-blame that I don't want you to fall victim to. I don't want you to start attributing hard days, challenging days, that what you're doing is incorrect, or then feel ashamed that you don't have it under control, or I can't believe I'm going through a flare again. Um, because that kind of starts to shape your identity. And then your identity and attaching it to your self worth with this condition could definitely spiral in terms of your anxiety, your depression, your isolation. So I think it's really key to think about the mental health aspect of this, when it comes to how we're naming things and reframing some of these challenging days. So I really want you to understand that hard days of eating are going to happen. They're not a character flaw. So you're not failing ever because you have a hard experience that you have to endure. So you're not failing because you're not doing the right things. You're having a hard experience because you're dealing with a hard condition. More so is a little bit of a reframe there. And one of the biggest messages too that I want you to kind of think about is you can't support yourself in terms of what you are shaming. So if you are shaming yourself and saying, this is proof that I'm doing things wrong, um, I'm not doing anything right. Why can't I get these things right? Why did this food work for me yesterday and not today? This increase in shame, become aware of that, please, because the increase in shame adds that additional pressure on you. And that additional pressure can then lend itself to more fear surrounding food. And that can all just feel a lot heavier. And then that can really play into that cycle of just becoming really isolated, right? And often we can get in that cycle here where you're not only dealing with the health condition at hand, but now you're dealing with your own harshness, your own critiques on top of it. And maybe you were already that person who had a lot of mental chatter going on and were chronically critiquing yourself. So, this is where I want you to think about gentleness. Gentleness is going to help create a little bit of room in your life to respond. And being gentle with yourself is not giving up, it's not being passive, it's not pretending things are okay when they're not. It's creating some internal safety within you so that you can slow down and you can respond more clearly. So I'd love to see for you to be able to slow down and not shame yourself and say, what would support me right now versus shaming me? And I hope this messaging comes through and hits home because I know from experience, even just with my husband who has chronic medical conditions, he's driven, he's active, he has so much he wants to do and knows he can do. But there are many days that he simply cannot. And that is so mentally taxing on a person when they have so many things they want to do and give, and their body doesn't allow them to. And this is same is true for you. So being able to create a sense of awareness, number one, with what your body is requiring of you. And number two, being able to then respond to that in a gentle way. I often say for any of my family members with chronic health conditions, when they do slow down, when they are able to maybe allow themselves a little bit of room, a little bit of internal safety, and maybe that means I'm going to go lay on the couch for a bit. I'm going to go take a nap. I actually can't work today. When we do that, in those moments, I'm usually like, I'm so proud of you. You're proud of me for taking a nap? Yeah, I'm proud of you for taking a nap. I'm proud of you for listening to your body. I'm proud of you for not always thinking you're tougher than this and can just push through or should be smarter than this. Unfortunately, the human body just doesn't work that way. We have to work with our body, not against it. So I think having a bit of a gentle approach versus, sitting here saying what's wrong with me, being able to shift things and say, what would support me right now versus shaming me. And that could look a little different for everyone and based on the day, but really think about giving yourself a little bit of more gentle approach during those really challenging days. And now a very simple statement I'm sure you've heard many times before is meet yourself with where you are. And maybe that seems simple and obvious, but it's really hard to do when you are someone who has a lot you want to do and your body is not meeting you where you want it to meet you, right? So to be able to take that pause and meet ourselves where we're at versus fighting fighting it and kind of coming into the reality of the day that we're actually having versus comparing it to the day that we really want, right? That ideal day on paper, or maybe it's weeks, maybe it's months. We know sometimes a flare is not just a one time thing, right? It's not like a 1 day situation. It could be weeks, it could be months, right? So we have to really think about how much energy are we wasting fighting our current reality. Okay. And I'm not saying that in a way to say, you give up all hope. That's not what I mean here. What I mean here is really just meeting ourselves with where we're at with that gentleness and thinking about that distinction of what is the day that I'm actually having today? Sometimes we have to let go of the ideal, the perfectionist type mentality and really meet ourselves within that day because we may not be able to have a perfectly structured day, easy day, emotionally calm. Maybe the day you're having is much lower energy. Maybe it's more symptomatic. Maybe it's more emotional. It's just limited. Maybe it's just harder. And that's when we really need to keep trying to force the ideal day onto the actual day that we're having. All right. That way we do not create more frustration and more shame. The more we kind of push back, like, nope, not having it today, not dealing with this flare up, I'm going to push through. Your body may not agree with that. And at some point, I feel like you pay for it, right? You ever have those days where you have pushed through and you end up paying for it? So being able to kind of stop yourself and say, all right, what is the day I'm actually having? And what is true for me today? What supports me today in this moment? Maybe it's not ideal, maybe it's not perfect, but let me just be honest. And that can be really, really hard to do, especially if you're someone who has like set rules of what you're gonna do and what you're gonna follow. And maybe that just like no longer matches the lifestyle that you're living now or that you can live now. It can create a lot of frustration, a lot of guilt that you can't show up the way you once did, the way your body once allowed you to. Um, it can kind of make you feel like you're doing something wrong. But, the supportive choice and all this is really just thinking about what can your body actually tolerate. And yeah, there's a lot of people that go about every single day and they never have to think twice about it, right? And it must be nice for them, right? But you all are equipped with the tools to have such a self-awareness of your body. In a way, I think it's a superpower. I think it's a superpower because you all are the ones that are able to truly be in tune with your body and what it's telling you. So I want you to think about like sometimes your breakthrough is not going to be about doing more throughout the day. I'm not giving you more to do. What you need to do is just meet yourself differently, an effort to kind of keep moving yourself forward. And permission changes everything. Again, maybe these are simple concepts, but sometimes I think we have to come back to these mental reframes of what we allow ourselves to do and to think, an effort to really repair our relationship with ourselves first and foremost, and with food. Because this could be a very volatile relationship you have with food, a little bit of back and forth here of how it's showing up for you. So, sometimes it's about just giving yourself permission, especially on a flare day or low energy days, days where you know your body is just not at its prime, to give yourself the permission to simplify, permission to repeat foods if you need to, permission to change your plans, permission to make your day easier. A lot of times we can think that means we're failing, we're doing something wrong because I do have to go to the couch and rest today. Or, you know what, I know that broth is the only thing that's going to go over well with me. I'm just going to repeat that all day long to make sure I'm getting some nourishment in my body. Maybe it's, sorry, I know we made plans, but I can't tonight. I do have to cancel on you. So a lot of times it can feel like we're doing something wrong when really you're just supporting yourself in this process. And support doesn't always look super impressive, right? Sometimes it's just very simple. And simple is very wise, especially with chronic health conditions, because your body's going to be unpredictable. So the goal may be for you just getting less perfect about it and really removing that unnecessary pressure that we can really put on ourselves. So I'm giving you that permission to keep it simple, keep it safe for yourself, and then let enough be enough for that day if it needs to be. So giving yourself permission. Maybe you have set rules in place. Maybe you have rules regarding food. I should be eating healthier than this. It's always a reminder to me as a dietitian. We think about the food guide pyramid that doesn't really exist anymore, but still kind of does. You think about eat more fruits and veggies and make sure you're getting in enough fiber because you're probably not getting in enough fiber, and make sure you're getting in heart healthy fats and all these general recommendations as a dietitian we give out and maybe were ingrained in you and maybe still are that you're fighting against that don't coincide with gastroparesis. So you have to think about, are you giving yourself these food rules that are kind of making your day even more stressed out? Maybe you're saying, oh, I should be eating healthier than this. I shouldn't have to eat this simple. I shouldn't have to handle, um, I should be able to handle more variety, excuse me. And like some of those rules could come up in your mind. Try to catch those. Try to catch those in the moment because all those are doing is creating shame for yourself. And that is what we want to get away from. We don't want to be creating shame about what you need to put in place to feel your best, or at least feel like you can get through the day. Because sometimes that's all we can do too, is set ourselves up in a way to feel supported that we can get through the day. And small wins do count. Like I said, a hard day is not a failed day, right? Sometimes the win here is not having a great day. The win is not spiraling. It's not working against your body all day. It's not having the thought spiral. The win is maybe asking for what you need. I don't know. There's a lot of people that you can be very proud, and it can be very hard to ask for help, especially on the hard days. Are any of you like that, where you struggle to either delegate or ask for help, or maybe just ask someone in your supportive group, like, I am struggling today. Like, maybe I need you to handle taking care of X, Y, and Z so that I can take care of myself a bit more today. I need to pour a bit more into me. That's a win. It's hard to do, but that's a win. So sometimes the win is just letting something be more simple. Maybe it's your eating that gets simplified today. Maybe it's your plans for the day get simplified. The win is just choosing a supportive step that can help you versus just giving up on yourself or creating that spiral of shame and guilt surrounding your day, because flare days can probably bring up a lot of shame. They can bring up a lot of those feelings that we talked about at the beginning of the presentation. Um, so just really think about support can look really different for you on these days. It could just be less food, it could be softer food, it could be giving yourself more rest, asking for help, maybe just giving yourself a little bit more flexibility and a little less pressure on yourself. It's the win here. Everyone thinks doing more is always better. And that's usually the opposite when it comes to gastroparesis. More is not more here. I want to talk about confidence here, because confidence, a lot of times people think comes with perfection, with nailing my days, with never having a flare means I'm doing all the right things. And that's what builds my confidence. But we have to get away from that mindset, because confidence is not perfection. There's no such thing as perfection, and there's no such thing as perfection in anyone's diet, regardless of your dietary needs. Perfection really doesn't exist. You want to eat in a way that best supports you, and especially for you, understanding that it could be different. It could vary, right? It could change. What once flared you up now does it, or vice versa. Never used to, now it does. What the heck? Confidence is really about steadiness, and it's building up self trust that can be crushed very easily because you feel like your body is no longer maybe connecting with your mind anymore. So it's really about thinking, even when the days are not perfect, I can respond in a supportive way. That is how you can build confidence. Confidence is not, I never struggle. Woo! It's, even when I struggle, I know how to come back to myself. And that's what we call pre-mortem. We have to think about planning for the fact that the reality is bad days are going to come, right? We like to live in this world thinking a bad day is never going to happen again. And of course, I wish that was the case for every single human, but we know that bad days are going to come. They will. So let's have a plan in place for how we're going to talk to ourselves, how we're going to meet ourselves, how we're going to support ourselves. That way we don't lead into that shame spiral that tanks our identity. We cannot attach our identity to the condition. We don't want to be our condition, right? So in effort to do that and keep our confidence high, we have to find a way to support ourselves. So understanding that even when I struggle, I can come back to myself, and I know how to do that. So in just asking yourself, like, what is the next supportive step from here for me? So confidence, I feel, is rebuilt. If you are someone struggling with confidence, it's rebuilt with just one supportive response at a time. And maybe that sounds silly. A lot of times people think confidence comes from really executing action, all the things that you're doing and accomplishing. But no, confidence really comes from your mindset and how you're talking to yourself and how you're responding to yourself during those difficulties, especially. And then being able to come back to yourself versus just turning it into a personal failure and kind of labeling that story and that narrative as, no, I'm a failure again. Because those are the stories you then hang on to and become part of your subconscious that then linger into other areas of your life that you don't want them to show up. So let's just be super aware of that. Hopefully I'm doing okay on time here too. Um, the social side. I have to touch on the social side because we can't talk about gastroparesis without talking about the social side and how much this really impacts our entire lives. Food is tied to everything. You can have people that say food is fuel, like that's it. And that's just not the case. Food is tied to celebration. It's tied to culture. It's tied to nostalgia. It's tied to family. It's tied to comfort. It's tied to a sense of feeling normal, right? To have a sense of normalcy. It's everywhere, it's around us. We can't get away from it. So it's additionally challenging when food becomes stressful because it then impacts more than just your meals. It makes you worry about what others could think about you. What if others think I'm high maintenance because I have to request something special? I don't want other people feeling like I'm the burden. Or maybe you just, because of those things, you shut down completely and just isolate and you avoid plans or making any plans because you don't want to be that burden that you're classifying yourself as. Um, I think grief deserves more attention than it often gets with this condition, because you're not just grieving food, you're grieving ease of life, ease of spontaneity, ease of not having to think so hard about everything that you're eating. So sometimes isolation can just feel easier than trying to be spontaneous or, not having to worry about what if I have to cancel plans. Maybe you're just thinking, I'm going to be in the moment worrying more than I'm actually going to be enjoying my surroundings. So that social and emotional burdens matters just as much as the practical side of things here. And I'm never going to tell someone how to handle these situations. I think these are very individual. They're very unique. Um, anytime I just feel like your energy is going to depend on the day, the moment, the hour, maybe the minute, right? So there may be those days that you're like, not necessarily want to classify it as isolating, but I need to cancel the plans to protect my energy, protect my peace, whatever it may be. So I did want to just like offer like some simple little go-to things here. If you are someone in social situations struggling with what to do, I always want you to be able to advocate for yourself. And I always correlate this, whether it's a weight loss client or a chronic health condition, to a medical allergy that could send you into anaphylaxis. Because if you have a food allergy that could kill you, you're going to speak up about it, right? And you're probably not going to feel bad about it because you're trying to not die, right? So I want everyone to advocate for themselves and understand that it's not you have to not worry about burdening other people or making yourself smaller to make other people feel comfortable, okay? You don't owe long explanations to anyone if you don't want to either. Because how exhausting can it be to all of a sudden have to educate everyone on what this condition means for you, how it's impacted your life, how it's impacted everything for you. And it can be quite exhausting. And maybe you're already exhausted. So you don't owe people long explanations. You don't have to give a long explanation. In order to deserve understanding from others. No, you do not have to give them your entire medical history, your entire medical chart in order to be met with understanding when you have plans. So I want you to remember that you're allowed to keep your explanation short with people and protect your energy here. Just a few simple scripts like I shared on the screen here is just some things you can say to people if you do want to keep it short and sweet. Like, I'm just doing what works best for me today. Thanks for understanding. I got to keep this low key. And the deeper tool here is just remembering that your needs are valid. Even if they're an inconvenience, the version of you that wishes this was easier, right? Like, your needs are valid. I'm sure you wish this was easier, but again, you have to do what's best for you and your needs. Doing what you need to do to kind of adjust your intake or how you eat when you're in outings or how you approach this with people. It's not rude. Keeping it simple is not being selfish. And just keep that in mind, that your feelings are valid, and this can be a delicate thing to approach with people, especially why is it with family members? Sometimes you would think they'd understand the most, and sometimes they're the most challenging, right? It's like, come on, you're family. Okay,
Hey,
moving
Kara.
along. Yeah,
We're right at time.
perfect. Okay,
If you don't mind, we've got a couple questions in the chat. If you
great.
stay on a little bit after to answer those, sorry to cut you off. I just
No, I'm
wanted to
glad you
let you
did,
know
because
we're
I
done.
didn't like track what time I should stop chatting. So,
It's
and you know
okay.
how I get, Sam.
But thank you so much. As I said earlier, I've worked with Kara for a really long time, and she's made a huge impact on my dietary health, my mental health. So I just appreciate her being here to share that with you. And if you're interested, there's more info in our participant packet if you want to reach out to Kara. So we're going to move on to our next session with Dr. Zachary Spiritos. He is a neuro GI who focuses on medically complex patients, and today he'll be talking to us about gastric dysmotility and the failure of the autonomic enteric axis. And Dr. Spiritos, when you're ready to go.
Hey, thank you so much, Sam. Thanks everybody for being here on a Saturday. That is awesome. Let me just get started and then cool. So let me bring up my screen. Can you guys see?
Yeah, you're good.
Okay. Okay. All right. So today we're going to talk about gastroparesis, but really break down why it happens, how it happens, the stakeholders in the motility and the sensation of the stomach, and then what happens when it breaks down and what can we do about it. So this is gastric dysmotility, failure of the autonomic enteric axis. So before I want to dive in, I kind of want to frame what we're actually trying to accomplish today. And I want to kind of get beyond the fact that gastroparesis is just slow motility or delayed emptying, and start thinking about it as a breakdown in a coordinated neuroimmune motility circuit. Second, we'll talk about how the stomach's different regions and their control systems normally work together to handle a meal. Third, we'll focus on why symptoms, especially nausea, occur, and how they're often driven more by abnormal signaling between the gut and the brain than by emptying just alone. And finally, we'll use that framework to think more clearly about treatment. And because the goal isn't just to speed up the stomach, it's to target the specific mechanism driving each patient's symptoms. So the stomach is best understood not only as a simple storage organ, but as a layered, highly coordinated neuroimmune system. When a meal enters the stomach, several things need to happen in very precise and synchronized way. So the upper part of the stomach, otherwise known as the fundus, accommodates so pressure doesn't build up in the stomach. And at the same time, the lower part of the stomach, otherwise known as the antrum, begins mechanically processing food, breaking it down in a very coordinated fashion. And then the stomach has to regulate how and when that material exits into the duodenum for absorption or the proximal small bowel. And what makes this system so complex, it is not just mechanical, it's controlled by multiple overlapping layers. There is the built-in neural network called the enteric nervous system, communication with the brain via the vagus nerve and sympathetic chains, and an internal electrical rhythm system called the interstitial cells of Cajal that helps coordinate timing. And there's even a local immune system that influences how everything functions and works together. And all of these layers constantly interact with one in real time. So when everything works well, this eating a hamburger feels effortless. But when these layers fall out of sync, whether it's the timing, the coordination, or the signaling, the stomach doesn't just slow down, it becomes disorganized. And that's really the framework we're going to use today, understanding gastroparesis not simply as slow emptying, but as a problem of disrupted coordination within the neuroimmune motility system. Okay, so each part of the stomach has a very specific and highly coordinated role. As I had mentioned, the fundus, or the upper part of the stomach, acts as a reservoir. And when you eat, it actively relaxes in a very controlled fashion to accommodate the meal without increasing pressure in the stomach and avoiding any discomfort. The antrum, or the lower part of the stomach, then takes over as a mechanical processor, just kind of like a blender, and it generates strong, coordinated rhythmic contractions that break down food into microscopic particles called chyme, which then passes through the pyloric sphincter into the duodenum. And the pylorus regulates timing and the flow of stomach contents into the intestines, ensuring that only properly processed materials enters the small bowel ready to be absorbed. Okay. So before we go further, we need to step back and take a 100-foot view and define the major systems that control the stomach. And there are really 5 key players: the enteric nervous system, which acts as the local controller; the vagus nerve and sympathetic chain, which connect the stomach to the brain or the central nervous system; the interstitial cells like a hall, which provide electrical rhythms; the local immune system, which regulates the environment these systems operate in; and the muscle of the stomach, which receives these signals and does the dirty work and churns food up into small particles. And what's most important is not just what each system does individually, but how they communicate with each other. Okay, so let's start with the enteric nervous system. So it is the intrinsic control of the stomach, and it is far more complex than people realize. It contains hundreds of millions of neurons, comparable to the central nervous system in the spinal cord, and is organized into 2 major plexi embedded within the wall of the stomach and the GI tract in general. First is the myenteric plexus, which is located between the muscle layers and is responsible for coordinating motility. And this is where patterns of contraction are generated, particularly in the antrum, where peristaltic waves need to be timed and organized effectively to process a meal. Then there's the submucosal plexus, which sits closer to the mucosa but plays a different but complementary role. It regulates secretion, blood flow, and interactions with the environment within the stomach, helping the stomach respond to nutrients and chemical signals. Functionally, the enteric nervous system operates through a network of sensory neurons, interneurons, and motor neurons. Sensory neurons detect stretch, distortion, and chemical signals from within the stomach. The information is processed locally by interneurons that send signals to the motor neurons, which generate the appropriate response, whether it's contraction, relaxation, secretion, or changes in blood flow. Importantly, the system can generate local reflexes independent of the brain, and coordinate gastric motility can still occur even without input from the central nervous system. It effectively works independently. When it comes to motility, the enteric nervous system regulates both excitatory pathways, which drive contractions via neurotransmitters like acetylcholine, and also inhibitory pathways like nitric oxide and VIP, which allow for coordinated contraction and then subsequent relaxation to allow kind of coordinated peristalsis within the stomach to break down particles into small, tiny pieces to allow absorption within the intestines. Then let's move on to the interstitial cells like Cajal, which are a crucial part of the stomach's control system. They sit at the interface between the nerves and the smooth muscle, and their main role is to generate an electrical rhythm that underlies gastric motility. Unlike the smooth muscle, which do not reliably generate any contractions on their own, the ICCs produce a spontaneous rhythmic electrical activity, and in the stomach, this occurs about 3 cycles every minute, and these slow waves propagate from proximally in the funnus to distally into the antrum. But the ICCs don't simply create rhythm in isolation. They are deeply integrated with the enteric nervous system. The ICCs are closely associated with these nerves and appear to help mediate neural inputs to the muscle. In other words, the enteric nervous system provides the excitatory and inhibitory instructions, while the ICCs provides the correct timing in which those instructions can be translated to the muscle. So that a relationship is very important. Oh, sorry, guys. If the ICCs are intact, but the enteric nervous system signal is lost, the slow waves may be present, but the contractions are weak. Conversely, if the enteric nervous system is preserved, but the ICCs are disrupted, the contractions can still occur, but they're incredibly disorganized and ineffective. So a useful way to think of this is that the ICCs are the pacemaker and the conduction system, while the enteric nervous system is the local controller that determine how that rhythm is used. The next crucial stakeholder in gastric motility and sensation is the autonomic nervous system. And the most important component here is the vagus nerve, which provides bidirectional communication between the gut and the brain. About 80 to 90% is actually carrying sensation fibers from the stomach to the brain, carrying information like distension, nutrient content, and chemical signals. This information is processed centrally and then transmitted via something called the vagal efferent nerve, which is the brain or the nerve from the brain to the gut, to regulate key functions, including accommodation, contraction tones, and pyloric tone. But the vagus nerve doesn't act in isolation. It works through the enteric nervous system, which we had just described. They synapse or communicate with enteric neurons and broadly modulate their activity. Rather than activating a single pathway, the vagus tends to influence the entire enteric circuit, adjusting the balance between excitatory and inhibitory actions. And the vagus nerve doesn't talk directly to the interstitial cells of Cajal. It communicates with them via the enteric nervous system. At the same time, the ICs are continuously generating slow waves, which create the timing window for contractions. In contrast, The sympathetic nervous system acts like a brake. It inhibits motility and reduces secretions. And it does this primarily by acting on the enteric nervous system, modulating neurotransmitter release and suppressing enteric activity rather than directly acting on the muscle. So the key concept is that the enteric nervous system generates the local motor programs. The interstitial cells like Cajal provide the timing, and the autonomic nervous system, like the vagus nerve and the sympathetic chains, modulate the overall activity and coordination of both. Okay, so what happens when we eat? So the system doesn't just turn on, it's a very orchestrated, coordinated event between all of these processes. As food enters the stomach, the first step is sensing. So the stomach wall stretches and it accommodates, and both the enteric nervous system and the vagus nerve detect this stretch and chemical composition of the food, and that information is processed locally and then also sent up to the brainstem. In response, the autonomic nervous system adjusts the system. So the vagus nerve increases its activity, signaling back to the stomach to enhance coordination and contraction, while sympathetic tone decreases, which the inhibitory mode of control of the stomach, removing inhibitory pressure on the system, and that creates a state of favorable for digestion. And from there, the enteric nervous system takes over locally. At the level of the myenteric plexus, it organizes the motor pattern by balancing excitatory signals like acetylcholine and balancing inhibitory signals like VIP and nitric oxide. At the same time, the interstitial cells like Cajal are doing their thing and generating a steady electrical rhythm in the background, about 3 cycles per minute. And when these systems align, the antrum begins contracting in a coordinated, wave-like pattern, breaking down food into chyme to be sent into the intestines. And the pylorus then regulates how much that material is slowly able to permeate into the small bowel. So it seems like a simple process is a very highly coordinated, orchestrated event between the motor, immune, and nervous system. We also need to talk about the immune system really quickly. And this is when we think about motility, we usually think of an issue with pacemaking cells like the ICCs and nerves, but the stomach also has its own immune environment. And the immune environment may play a really significant role in how the system works. The immune system includes cells like macrophages, mast cells, lymphocytes, and under normal conditions, these cells help protect the stomach lining, maintain the barrier between the gut and the external world, and support healing. The immune system interacts with the stomach's nerves, pacemaker cells, and muscle. So if it becomes overactive or unbalanced, it may interfere with how the stomach moves and really disrupt the surrounding and adjacent nerves. In gastroparesis, especially idiopathic, post-viral or autoimmune, or diabetic forms, there's emerging research that suggests that patients may have increased immune cell activity not only within the mucosa or the superficial lining of the stomach, but also the muscle as well. And this may be linked to the overall maladaptive behavior of the stomach overall, leading to gastroparesis. Okay, so what happens when all of this breaks down? So a helpful way to think about gastroparesis is not just a single disease, but a final common pathway with multiple different inputs or possible ways to get there. Meaning that many different types of injury can affect different parts of this gastric control circuit, ultimately leading to the similar end result of delayed gastric emptying. And and so multiple things can happen: disruption of the vagus nerve, interruption of the interstitial cells like Cajal, um, uh, the local immune system could be negatively affected. And when each of these stakeholders are disrupted, it can lead to delayed gastric emptying. We'll get to that in kind of individually. So let's break down the different subtypes of gastroparesis, or the most common ones, and how it ultimately leads to gastroparesis. So post-surgical is vagal disruption. So effectively, the vagus nerve is disrupted after surgery, like a foregut surgery, like bariatric surgery, surgery for peptic ulcer disease, a hiatal hernia, things like that. So this is very, very simple, and it's best understood as a mechanism-driven disorder where its vagus nerve is effectively disrupted. And as a result, the stomach may lose its ability to properly store food, generate effective contractions, and regulate outflow. And the result is poor gastric emptying. The most common symptoms are nausea, vomiting, bloating, and early satiety. And we will kind of start to make sense of why, based on the mechanism of injury, why people get certain symptoms. So remember this. So nausea, bloating, early satiety. So next is diabetic gastroparesis, which is best understood as diabetes affecting multiple parts of the stomach's control system. And instead of an isolated problem like in post-surgical gastroparesis, diabetes can affect multiple levels of control here. It can affect the nervous system, which obviously connects the brain to the stomach, or the vagus nerve, which connects the brain to the stomach. It can damage the local nerve network itself, the enteric nervous system. It can really affect the interstitial cells of Cajal, and it also can affect the local immune system. We're realizing that there can be these pro-inflammatory macrophages within the wall of the stomach in gastroparesis. So when those systems start to break down together, the stomach loses coordination, and it may not relax properly to receive a meal. It may not grind food effectively, and it may not empty in a smooth, coordinated way. So the issue is just not that the stomach is slow, but it's that the normal process of storage, processing, and emptying becomes very disorganized. In diabetes, the most common symptoms are bloating, stomach fullness, and early satiety, followed by nausea and vomiting. And just like post-surgical gastroparesis, the symptoms map down to the breakdown and how the stomach coordinates its normal functions. But here the driver is just not vagal injury, but diffuse metabolic and neurologic injury to the nervous and the immune system of the stomach. The third type is idiopathic, which is usually post-viral, or which can be my interpretation for a lot of these patients. It's probably an autoimmune flavor, but it's kind of a very heterogeneous patient population, and it definitely gets more complex. There isn't a single clear mechanism here, and nor has there been a lot of data on this patient population. But most patients report a fairly sudden onset of symptoms, and around 20% describe a viral onset or prodrome. And in these situations, we can kind of interpret or extrapolate that perhaps this is a kind of a post-viral autoimmune process, which can happen. And at the tissue level, we're starting to see evidence of immune system involvement, particularly increased immune cells within the stomach, which may interact negatively with the enteric nervous system and interstitial cells of Cajal. But the exact sequence of events still needs to be mapped out. Clinically, this group looks a little bit different. These are typically younger women and certainly still have nausea and vomiting, but they have a lot of abdominal pain as well, which is very interesting, considering the immune, that this may be kind of more of an immune process than the other two. And so let's talk about why symptoms happen in gastroparesis in the context of how the injury happens. So what's very important to realize or take note of is that symptoms do not arise slowly from delayed gastric emptying. So when you look at the data, gastric emptying, so how much retention of food is on a gastric emptying study after 4 hours, only inconsistently and sometimes not at all predicts symptom severity. So some studies show that early satiety or getting full early is the only symptom consistently associated with delayed gastric emptying, whereas other symptoms have no relationship at all to gastric emptying. So you can have a patient with severely delayed gastric emptying who's actually relatively okay, and another with very mild gastric emptying with significant nausea and vomiting. And this tells us that it's not just a mechanical problem with food sitting in the stomach that causes symptoms, but the symptoms, it's a whole network problem, which we'll break down. So take nausea, for example, which is the centerpiece of gastroparesis. Nausea is not really caused by food sitting in the stomach. It's fundamentally a neuro and autonomic phenomenon. It occurs because the stomach sends abnormal signals via the afferent vagus nerve from the stomach to the brain. And so communication with the stomach, like distension or inflammation, activates vagal afferent fibers, which send this information to the brainstem. And then the autonomic nervous system is also involved. So when the brainstem interprets that information, it sends out signals that have reduced parasympathetic tone and more sympathetic tone, generating symptoms of queasiness, sweating, kind of that mouth-watery feel, pallor and queasiness. So nausea is not just about slow emptying; it's about abnormal signaling from the stomach to the brain, and then the way in which the brainstem interprets those signals. That's why nausea does not really match the degree of delay on gastric emptying. On the other hand, early satiety and post-meal fullness is what I interpret as kind of impaired accommodation, so that when the fundus relaxes when we eat, that may not work very well. And that is not really kind of that element is not necessarily seen on gastric emptying studies. And abdominal pain is probably the clearest example of how gastroparesis is more than motor, because it doesn't correlate with gastric emptying whatsoever. And it reflects something called visceral hypersensitivity, which is a term that gets thrown around a lot and largely driven by the immune system. One visceral hypersensitivity is effectively the notion that we feel everything in our intestines more than we should. And there's pain when there shouldn't really be pain there. There's no infection, there's no ulcers, no cancer, anything like that. And we're realizing that visceral hypersensitivity may be driven by sensitization of nerve endings by a lot of immune cells, namely mast cells, releasing neurochemicals like histamine, tryptase, nerve growth factor that can really sensitize nerves and cause a lot of stomach pain when, quite frankly, everything endoscopically or macroscopically looks healthy. Okay, so where does gastric emptying fit into all this? It's important. It can help confirm delayed gastric emptying, especially when performed with a proper 4-hour scintigraphy, but it's only part of the story, and that's why treatment has to be individualized. So let's talk about treatment strategies and kind of how we can kind of tailor these to patients, because everybody's treatment strategy and approach should be different, tailored to why they have gastroparesis and what their dominant symptoms are. Okay, so we always talk about diet therapy first. It is cornerstone to gastroparesis therapy. And the basic idea is pretty intuitive. If the stomach is really struggling to grind up food, you want to give it food that is easier to process. So the diets that we find work the most are small particle diets, which effectively are foods that are already kind of broken down. Think of mashed, cooked carrots, blenderized foods, mashed potatoes, things like that. If you think of the stomach as a blender, these are kind of pre-blenderized foods. Lower fat meals also seem to be much better tolerated. Mechanistically, fat really delays the rate at which the stomach empties, so that makes sense. And there's also some observational data on food patterns, namely that patients tend to report that fatty, spicy, acidic, or high roughage foods are harder to tolerate, whereas bland, starchy, sweet, and salty foods are easier to tolerate. We don't have a ton of time left, so we'll briefly talk about medications, but like how they work. So metoclopramide, Reglan, we all kind of know about this. It's the most commonly used medication in gastroparesis. So it works centrally by blocking nausea receptors within the brain, and also somewhat helps improve motility as well. What it doesn't do is it doesn't affect the way that the vagus nerve communicates signals from the stomach to the brain, which, if we're extrapolating that's the main mechanism with which nausea and symptoms happen, it doesn't really affect that very much. So that's reflected in the trials that, unfortunately, it's not an overwhelmingly successful therapy. Symptom improvement ranges from about 30 to 40%. And studies show that it does improve gastric emptying, but as we know, gastric emptying, just improving that does not necessarily reflect improvement in symptoms. And there's also kind of more neurologic side effects than we'd like, kind of acute dystonia, which is kind of like muscles locking up in a very, very scary and anxiety-provoking way. Tardive dyskinesia, which is a irreparable kind of ongoing movement of the mouth with long-term use. So doesn't work incredibly well. For some, it is a godsend, but also has kind of more side effects than we like. So we wish we had better tools. Let's just say that. Erythromycin is another cool one to talk about. So it increases motilin, which increases our migrating motor complex, which is kind of this sweeping wave within the intestines to clear food and debris. And erythromycin really just improves gastric emptying, and doesn't really work on central nausea receptors like Reglan does. And in clinical trials, it works about 40 to 50% of the time, which again is not ideal. You'd kind of want more efficacy. But again, just going back to like a medication that just improves gastric emptying doesn't do everything, right? Because gastroparesis is far more nuanced than that. It also suffers from tachyphylaxis, which means that the more that you use it, the less efficacious it will be. Okay, mirtazapine. Mirtazapine is a really cool one because this really works on it's a neuromodulator, which effectively changes the way that signals are sent from the gut to the brain, and this really works for nausea. So oftentimes pairing this with a medication that helps with motility it can be a nice option in gastroparesis if you're looking for pharmacotherapy treatment. So in one study with refractory gastroparesis, about 3/4 of patients had improvement in nausea and 2/3 in vomiting, with statistically significant changes as early as 2 weeks. So this is a neuromodulator and really affects the way that the vagus nerve communicates to the brain. Then a gastric emptying electrical stimulator. There's a lot of kind of misinformation, or I think a misperception of what this does. The thought is that it paces the stomach just like a cardiac pacemaker does with the heart, but it actually doesn't improve contraction very much or emptying of the stomach. It really just works on the afferent signaling from the gut to the brain, kind of like a neuromodulator does. So what it does, it really helps with nausea and vomiting, but doesn't really help with motility a whole heck of a lot. So it's very interesting because a lot of people think that it works just like a cardiac pacemaker, when in fact it's a neuromodulator, kind of a la mirtazapine. And lastly, I want to talk about immunoglobulin therapy. A lot of folks have post-viral, idiopathic, questionable autoimmune gastroparesis. A lot of these patients may also have POTS as well, which is a presumed autoimmune condition as well. And there's a growing body of data that immunoglobulins can really help, which is kind of a cool thing because to date we've just used medications that improve motility, right? That cut the pylorus, that change the way our brain perceives nausea. But this is different because this is an immune therapy, and there's early signals that it may work. We don't have any randomized control trials. We have kind of small observational studies, and the early returns seem quite promising at 4 to 6 months. But I think we have a lot more research to do here. But it's pretty cool for the future of gastroparesis, where we certainly do want more tools in the tool belt. Thank you very much.
Thank you, Dr. Spiritos. Andrew's going to take a few questions, if you don't mind.
All right.
Oh,
Thank you.
absolutely. Yeah.
Thank you again for kind of providing us with that breakdown. I found that to be very helpful. So we have a few questions coming in from the chat here. One is from Helena. Helena is asking if you ever notice a relationship between several conditions, and she names these conditions with rumination syndrome and um, visceral hypersensitivity. So have you ever noticed a relationship between those two?
Yeah. I mean, there's rumination syndrome is what is thought to be kind of a maladaptive behavior to eating, where you have kind of paradoxical contraction of the stomach and relaxation of the sphincter, of the lower esophageal sphincter that pushes food upwards. Do I see this with visceral hypersensitivity? Not a ton. Everybody's so incredibly different. It's not a pattern that I see come together a lot, but I can imagine, certainly envision common pathways with both would happen. I think visceral hypersensitivity is kind of more. It's an inflammatory process, typically involving like mast cells and this thing called TPRV receptors. But, I think that the I always look for like what are interventions that could potentially help with both. And, we do know that stress makes visceral hypersensitivity a lot worse. And there's something called corticotropin releasing factor, which is a stress hormone that can make mast cells angry and cause a lot of pain. And we also know that kind of stress can also make stress is such a silly word, but like perceived stress can really help, can really make rumination worse as well. So, that's the kind of common pathway there. And I would say that like there's some work on the DBGI front, like working with a GI psychologist may not be a bad idea in that situation, but it's obviously very nuanced.
All right, thank you. Our next question is: have you ever heard of immunoglobulin? Excuse me, immunoglobulin therapy being used orally for gastroparesis?
I don't think there's oral immunoglobulin therapy. So it's intravenous or subcutaneous. And to date, uh, there is, in terms of the trials for IVIG for gastroparesis, intravenous is the only one that's been shown to be effective, albeit the subcutaneous form hasn't been studied yet.
All righty, thank you for that. Our next one comes in from Susan. She's asking, can you say more about the mast cells and the MCAS and the role in dysmotility?
Yeah. So, I think one of the takeaways I think that I wanted to provide here is that the immune system probably plays a bigger role in motility than we think. Right? We just say that it's an issue with the muscles and the nerves, but I think the immune system is playing a really big role here. So, the data is not there yet for mast cell. Like we're still flying this plane. We're building this plane in the sky. It's just we're collecting data as we go. But I do see that people's motility can dramatically change. Like if someone has mast cell activation syndrome, by treating that, their motility can improve dramatically. I've seen people's really bad constipation, refractory to multiple laxatives, get better with mast cell therapy. Conversely, some people with mast cell have more loose stools, and that can get better with mast cell therapy. So there is, I think that the mechanisms have yet to really been to be elucidated, but mast cells can really affect GI motility. And typically I see people have both, they're both constipated and diarrhea. And by addressing that, dietary means, lifestyle, pharmacotherapy, like things can really straighten out, which is kind of cool.
Awesome, thank you. I think we have time for one more question. Michael's asking, what about EDS hypermotility and GI motility connection?
Yeah, I mean, that's a really big,
Yeah, I know it's a
that's really
it's
big.
a big scope to
That's
answer.
an hour, that's a 2 hour talk in and of itself, right? And so, um, when we talk about hypermobility EDS, a lot of those folks often have mast cell activation syndrome, right? And so mast cell can cause a lot of motility issues like I just mentioned. But there's also some of these patients have small fiber neuropathy, which is where there's damage to the nerves that communicate with the muscles. And you can get dysmotility, you can get gastroparesis, right? You can get small bowel dysmotility, you can get colonic inertia or slow moving colon. So, um, you know, there's a lot of reasons why motility may be affected in someone with hypermobility. And there's also visceroptosis, where there's ptosis or sagging of a lot of the organs in the intestinal cavity. So everything just kind of sits a little lower. And so if you can, sometimes we see the colon just sitting in the pelvis and it just can't move very well if the architecture with which the muscles need to squeeze is not operating properly. So, the motility is usually altered in someone with that obviously someone who I see in clinic is going to have some altered motility just by the nature of seeing me. But uh, there's just a lot of different inputs there. And I think it takes like a very detailed history and working through what's worked, what hasn't worked, diet, lifestyle, stress, medications, pattern of symptoms to really get a sense of what's driving someone's symptoms.
All right. Thank you for that. I think that's answers most of our questions. I know there's a few more.
We'll
Um,
follow up.
yeah. But I think just to kind of echo what Jillian and Matthew said, I think you really hit the nail on the head in making us more knowledgeable. So we appreciate it.
Yeah, of course. Thanks for having me.
Yeah, thank you so much. And I do want to mention, for those of you that haven't checked it out on our YouTube channel, Dr. Spiritos did a wonderful webinar talking about some of the comorbidities that you guys are bringing up in the chat. So answered a lot of those questions over there if you want to head over after this is done and take a look at that. He's always full of information. You can always follow him on social media too, because that's where I've learned so much. So thank you again, Dr. Spiritos, for being here with us today.
Of course. Thank you so much, Sam.
All right. So I know we're over time just a smidge, but that's just the nature of how these things go. So earlier this year, we put a call out for some podium and poster presentations for researchers who are exploring innovations in GI motility. We're really excited to share that we have not one, but two presentations for you today. In your participant ebook you received in your email, we also have an additional abstract by Zenowell. So the first one up today is a presentation from Alimetry. So Daphne, you can go ahead and unmute and take it away.
Thank you so much, Sam. Just give me one moment. I'm just going to share my screen. So hopefully you can all see that. Perfect. So thanks for allowing me to speak. It's a real pleasure. So a bit of background on myself. I'm been in this area researching for about 7, 8 years. I'm from Australia, as you can probably tell. That's where I did my PhD in motility. Then I started working on clinical trials with Alimetry, and then I moved over to the US last year to be a medical science liaison. So today I'll be talking to you about a major shift in how we understand and treat gastroparesis using our novel tool called body surface gastric mapping and our new Auckland classification scheme to help guide personalized care. So we had a lively discussion about this earlier. So for decades, gastroparesis has been defined by a single test, that is gastric emptying. But as many of you know, it is a flawed test as it only measures how fast food moves through the stomach. And this key hallmark study from 2021 by the Gastroparesis Consortium ignited this debate and showed that gastric emptying results were highly labile, meaning that if patients took the test again in a year, over 40% would receive a different diagnosis. They also found that gastric emptying did not correlate with symptoms, nor did it tell us why the stomach may be struggling. So the paper ultimately concluded that gastric emptying studies are of limited utility. And we heard some patient stories earlier, and unfortunately, as a result of this current standard of care, many patients then enter this cycle of frustration, often taking over 5 years to diagnose, to receive a diagnosis, involving multiple tests with inconclusive results, and a lot of trial and error therapy without symptom resolution. So there is now a need to move beyond the gastric emptying alone and actually understand the why behind patient symptoms. So we know that there are several different causes to symptoms, from sensory on the left-hand side to motor causes on the right, like dysrhythmia, which is like similar to cardiac dysrhythmia for your stomach, which emptying alone cannot distinguish. And this is where we come in, using our new tool called Body Surface Gastric Mapping, or BSGM. This is similar to having an EKG for your stomach, and it measures the underlying gastric electrical activity, which drives stomach contractions. Our BSGM system is called gastric Alimetry. It's non-invasive, radiation-free, and consists of these three parts shown here. So you've got the array on the left, which is a wearable patch that sticks on the abdomen and has sensors that listen to the stomach's natural electrical signals. This is attached to a reader and is all operated by the gastric Alimetry app. This sets up the test and also captures symptoms in real time. The standard test is about 4.5 hours, and that includes the test setup, half an hour baseline recording during the fasting period, 10 minutes to have a standard meal, and then a 4-hour post-meal recording. During this time, patients remain seated in a reclined position. They use our app to record exactly how their upper gut symptoms are from 0 to 10 every 15 minutes, while the array itself measures all the stomach activity. And also at the start of the test, we can look at the gut-brain well-being to assess the gut-brain axis link. And this is an optional survey that patients may complete to assess anxiety, stress, and depression over the last 2 weeks in relation to the stomach activity. So after the test, this detailed report is automatically generated for the clinician. It combines the gastric physiology, the symptoms, and how they're associated with the stomach, as well as the gut-brain well-being survey, to provide the clinician with a more holistic view behind what could be causing a patient's symptoms. So at a very high level, this is what a normal and abnormal report looks like. And to keep it really simple, the plots at the top are called spectrograms. The frequency is shown on the y-axis, and the amplitude or strength of contractions is shown in yellow over the 4.5 recording period. We also have validated metrics, as well as a normative reference interval, which tells you whether this activity is normal or abnormal. And we also look at the symptom burden over this time and how it changes with the meal. So to start off, on the left, you can see what a normal stomach should look like. So after the meal, you should see a nice, clear, stable yellow band that appears for about 1 to 2 hours at around 3 cycles per minute. So this is indicative of a normal and stable gastric activity. On the other side, on the other hand, when the stomach is abnormal, this is the picture that we see, where the activity is now very scattered or all over the place, very unstable. And we think that this is indicative of a neuromuscular dysfunction. And I'll go into a little bit more detail about it later. So now we've used all this data and developed an interim framework that we call the Auckland Classification Scheme. It was developed by an international consensus group of clinicians and experts using over 4,500 clinical tests. And as you can see on the right, it sorts patients into these 6 specific subgroups or phenotypes based on the objective biomarkers and distinct BSGM patterns rather than just gastric transit time alone. So in our initial study of about 16 gastroparesis patients, more than 80% of these patients were phenotyped into a specific category, and we were able to place them into these 2 main overarching groups. The first one being motor predominant or abnormal phenotypes. And this includes the dysrhythmic one that I was mentioning earlier, but 25% of patients fit within this, and this is denoted by this scattered pattern that we see on BSGM. The rhythm is very out of sync, very unstable, and this is likely due to a dysfunction or loss in the stomach's pacemaker cells, the interstitial cells of Cajal, or ICC, which generate the electrical activity that we see. And so we think this is a neuromuscular dysfunction causing it. Another phenotype that we saw was the low meal response, and about 19% of patients fit within this. And this is where we see a long lag in activity before it ramps up towards the end of the test. And we think that this is because the stomach is not contracting properly to move the food through. And so we think this is a gastric hypermotility or weak stomach contractions causing it. And in these cases, we would say focus on therapies that target that physical machinery or working of the stomach, such as prokinetics. And so we have emerging evidence that indicates that this phenotype here, the low meal response, tend to respond better to prokinetics, while those with a dysrhythmic phenotype appear to worsen on prokinetics. And we're building on this data and really linking the phenotypes to the treatment. Another group that we saw was the sensory predominant or normal phenotypes. Here, the stomach is working normally, but the symptom profiles are very different. So in this case, the sensory motor, about 25% of patients fit within this. And this is when the symptoms are meal responsive, so increase after the meal, and also correlate with the stomach activity. So we think that the brain feels very overly sensitized to the stomach's movement and therefore presents with intense symptoms such as pain or nausea. And we think this is related to a hypersensitivity and/or impaired gastric accommodation. The other one that we saw was the continuous, and nearly 13% of patients fit within this. And this is when the symptoms are just relatively constant throughout the test, don't relate to the meal, and we think that there's a dysregulation between the gut, the signals of the gut and brain, or it could be a non-gastric issue. So in these cases, we wouldn't focus on the physical working of the stomach, but more on those signals, such as using neuromodulators that target the gut-brain axis. So overall, we've shown that the Auckland classification scheme allows us to specifically classify patients into these 6 distinct phenotypes. It is important to note that no patients were phenotyped into the delayed onset or high frequency, but we did look at a very small cohort, and we have ongoing research to validate this in a larger cohort. As mentioned earlier, it is clear that gastroparesis is a heterogeneous and complex disorder, so it's not really a one-size-fits-all approach, and gastric emptying may not be the primary cause. There are differing mechanisms underlying symptom genesis, and phenotyping using this scheme allows us to differentiate them and have a more targeted approach to therapy. And just note that we are going to publish this Auckland classification framework in the near future. So to bring this all together, for years we focused on gastric emptying. We know it's radiation-based, only measures how fast the stomach is moving, is highly variable, and it's non-specific. So we're now moving beyond this to cutting-edge technology like gastric mapping, which tells you the why behind the symptoms. It's non-invasive, radiation-free. Instead of guesswork and trial and error, we're actually providing objective, actionable biomarkers that help identify the specific mechanisms underlying symptoms, providing more clarity through our phenotypes that differentiate between a motility and sensory disorder, and ultimately helping to guide and direct personalized therapy with our emerging evidence linking these phenotypes to treatment, such as the prokinetic data mentioned earlier. And finally, I just want to mention that this test is FDA cleared. It's clinically available in the US, and we're currently using it across several hospitals in the US. So thank you everyone for your time and allowing me to present. If you'd like more information, you can reach out to our email, and I'm happy to answer any questions. Thank you.
Thank you. That was a great presentation. Very fascinating. Just real quick, we do have 2 questions. When will the gastric mapping be available for patients already diagnosed with idiopathic gastroparesis?
It's already available across the US. So we're FDA cleared. We have several clinical sites across. So you can speak to your local gastroenterologist, see if they're aware, and they can refer you to a hospital or clinic that does it. Otherwise, you're more than welcome to contact our team, and we can also help you out with that.
Excellent. Thank you. And how does it compare to the pill cam, which is no longer available?
Yeah, the smart pill, is that correct?
Yeah.
Yeah, so unfortunately that's no longer available. We did some very, very preliminary studies. This was when I was back in Australia. And so we did find correlation between the really severe phenotypes, so dysrhythmic, with severely delayed gastric emptying so far. But we, because it was discontinued, we didn't end up completing that fully. But that's what we saw so far.
All right. Excellent. Thank you. We appreciate you sharing your research with us. And there is a couple other comments if you want to go in and take a look at them in the Q&A.
Will do. Thank you, everyone.
Thank you so much.
All right. So, thank you so much again, Daphne, for that. That was really great. We've learned so much. And without further ado, our second presentation is here with Raymond from Aclipse Therapeutics. So, Raymond, if you want to go take it away.
Very good. Well, thank you very much, Samantha and the G-PACT team for inviting us. And I'll go ahead and share my screen. And so presumably you're seeing this in full screen mode.
You're good.
Okay, very good. Okay, so well, Eclipse Therapeutics and our collaborators are developing a drug candidate, M107, for the treatment at this point of idiopathic gastroparesis, and we hope to extend that, as we go forward in the development path. And so let me see if I can. There we go. So first, just from the big picture, we're a clinical stage company focused on the neuromuscular area, where, as we look at it, the interface between the body's nerves and the muscles. And we have two drug candidates that we're taking into development: M107 for gastroparesis, which is entering phase 2 in collaboration with the Mayo Clinic. So the phase 2 is being done at Mayo, and I'll talk more about that in later slides. And we believe that M107 is really a best-in-class drug, and also the first potential drug that's really going after treating the disease versus just treating the symptoms of the disease. Our other molecule is M102, a neuroprotective molecule with it's really focused in the treatment of ALS or Lou Gehrig's disease, traumatic brain injury, and some other diseases. And it's an NRF2 and HSF1 activator, and it's entering a phase 1 program in Australia. So going back to gastroparesis, again, the audience here knows most of the things on this slide, certainly. But, right in the middle here, there's a large previous patient survey that's in the literature that really says that 65% of patients are dissatisfied with their current therapy, and certainly through today's webinar, you've heard much of the same. And at least one way to think about that is that all the current drugs are just managing symptoms. And what we're trying to do with our M107 is really target the disease and target the biology of the disease, which really is macrophage-based immune dysregulation, and we're going after that piece of the mechanism of the disease. So first, in terms of the molecule, it's a once-a-day dosing oral molecule, small molecule, and we formulated it into an orally disintegrating tablet for the gastroparesis patients. And this molecule has been approved in South Korea and South Korea only for the treatment of type 2 diabetes. And so it's a new chemical entity in all the geographies outside of South Korea. But that South Korean data generated a safety database of over 3,800 patients and healthy volunteers in the safety database. And we've taken all of that data from South Korea, taken it to the FDA, filed for an IND clearance, IND, which then got cleared. We've conducted a phase 1 program really just to confirm the orally disintegrating tablet performance, and a type C meeting to confirm the phase 2 study parameters. And so that's where we are right now. And so a little bit on mechanism, and you heard earlier in the webinar various parts of mechanisms and aspects of the mechanism of the disease. But also, in that was really talked about an imbalance of pro-inflammatory and anti-inflammatory macrophages, so immune imbalance. And so if you look at gastroparesis, there's a good body of data that says there's a high level of M1 pro-inflammatory macrophages in patients that have the disease, and that there's a
a decrease in the interstitial cells of Gehal, the pacemaker cells that cause the timing of the stomach, as we heard before. There's also an increase in the fibrosis of the pylorus at the exit of the stomach. And all that adds up to both slowing gastric emptying and decreasing overall stomach functionality. What we hope to do with M107 is really reverse that, is really take and drive to an M2 anti-inflammatory macrophage population, which again, there's data showing that that could increase the ICCs, the interstitial cells of Gehal population. Also, there's anti-fibrotic aspects of the molecule, so we're decreasing the fibrosis, and then overall, goal of the therapy is restore the macrophage balance and increase gastric function. So some animal data. This data was done in diabetic mice, and over the treatment period of the experiment, you can see in the placebo-treated arm of the diabetic mice, they had a 99% M1 pro-inflammatory macrophage population at the end of a 20-week treatment period. And in the M107 treated arm of the study, essentially we're able to drive that pro-inflammatory macrophage population to an 82% no longer pro-inflammatory macrophage population. And there was in the experiment a significantly greater proportion of M2 anti-inflammatory macrophages. So it is achieving, at least in animals here, the therapeutic effects that we were looking for. There's also a human proof of concept that's available. This was a Johns Hopkins study, an open label trial of pioglitazone, which is an older PPAR gamma activator, or M107 is a PPAR gamma activator. So pioglitazone is an older activator, and a trial was done in idiopathic gastroparesis at Johns Hopkins. And you can see some of the results here, again, open label, but the conclusion of the principal investigator and his team here is these findings point to the possibilities of an effective disease-modifying medication for the first time, and where its effects are known on macrophage activation. So this is sort of pointing the way in this open label trial. And as I said, pioglitazone is a PPAR gamma activator that is approved for type 2 diabetes, but it also has a boxed warning for bladder cancer and congestive heart failure on the label, where what we have is the same class PPAR gamma activator, but a best-in-class drug with our M107. And based upon efficacy, we have 37x higher potency than PO by one measurement and 21x higher potency than PO from another measurement. And if you look at the safety profiles, where the safety compared from the 3,800 patient safety database to the PO label, you can see in all these different pieces of safety, we have advantages. And so let me move on. So we're getting ready to do a phase 2 trial in collaboration with the Mayo Clinic called the LOGAS trial. And it's a double-blinded trial over 12 weeks of treatment with 130 idiopathic gastroparesis patients. It's going to happen as we go through this calendar year. We're right now doing all the blocking and tackling to get the trial all up and running at Mayo. I think Mayo's doing the vast amount of that work. They're really the mover and shaker here. But there's 3 sites you can see here in the center of the slide of patients that will be dosed at all those 3 sites, where the key inclusion criteria are adults over 18 and a gastric emptying test, and we heard some of the aspects of that in earlier presentations, as well as a gastroparesis cardinal symptom index score of greater than 2.7. And we're excluding diabetics from this trial and no GLP-1 drug use from this trial too. We're trying as best as we can to get a homogeneous population for the trial. Also, from a primary and secondary endpoints, there's a whole series of them. There's some level of I'm not sure controversy is the right word, but certainly discussions among the FDA and physicians as to what is the right endpoint. And there's really three different patient-reported outcomes that are out there. The PAGI-SIM and two different versions of the GCSI. All three are going to be in this trial so that we can really understand the performance of all three as we go through the trial. In addition, we're also taking exploratory endpoints for a whole series of biomarkers and the Alimetry body surface measurements that Daphne just talked about as well. And that's a trial. Again, I wasn't exactly sure what Daphne's slides were going to be, but we're using that same technology here to measure the patient pre-dose and then at the end of the 12-week dosing period. And our goal here is really to understand so that we can best set up the design for a phase 3 trial. And that includes patient segmentation, and if there are certain phenotypes that have a greater drug response or a greater ICC cell population response, these are all the sorts of things we're trying to understand out of the trial. And again, this is just the landscape, at least from a drug perspective, in terms of therapies and everything that's either approved or in clinical trials right now are all symptomatic treatments, and we're really trying to go at it with the first disease-modifying treatment. And so, thank you very much. Certainly, we have, thank to Dr. J. Pasrica, who's the principal investigator of the upcoming trial, and 10 investigators at Mayo Clinic to conduct the trial, and various other collaborators from CKD, Pharma Directions, Alimetry, and certainly our thanks to G-PACT, and certainly thank you to all the gastroparesis patients as we move through the trial and hopefully have success that then can drive this to phase 3 development. So thank you very much, and I'll stop there.
Thank you. It was excellent. This is Amanda again. I'm going to be running the Q&A. So we do have one question.
Sure.
How do you get involved in the trial? How can...
Well, sure. Here, let me turn off my share if I can. Oh, there we go. Okay. Okay. So the trial is not running yet. It should be running. We're hoping that in a 3 or 4 month period, we will be, or Mayo Clinic, I should say, will be dosing patients, and we're trying to do all the blocking and tackling to get there. So when we're at that point, there will be the trial will be announced or listed on clinicaltrials.gov. And on the clinicaltrials.gov site will be, information that will allow patients to contact the physicians and/or the study coordinators at the Mayo Clinic to possibly be included in the trial. And also, as we go forward, my contact information is in the information, for this conference. And so certainly I'll be happy to direct people. It's still too early in that, but 3 or 4 months from now, certainly we hope to be or Mayo hopes to be up and running, and be happy to be a facilitator wherever we can.
All right. Well, thank you so much, Raymond. That was great. And we always love to hear about what people are doing in research, because one of the number one questions we get is, does anybody care about us? And what is anybody doing? So thank you so much for sharing that with us today.
Thank you very much for the opportunity to do so. Thank you.
Okay, so we are at the end of today's conference, and That was a lot. So thank you to all of you for being here with us today. I am so grateful to each and every one of our attendees for staying with us today. And a big thank you to all of our sponsors, Peptamen, Zenoel, and Tummy Drops for helping make all of this possible. And to all of our speakers and our panelists who are here, we could not have done it without you. Since we've been here for a while, I'll do my best to be short and sweet so Jim doesn't yell at me when I go on a tangent. If you've followed G-PACT for a while, you've probably noticed some changes. We've been hard at work behind the scenes to grow our programs, community, and advocacy and awareness efforts. Our podcast, Surviving Out of Spite, hit its 1-year anniversary just yesterday. We've got a few episodes up of our newest YouTube series, Spoonful of Spite, and I am so excited to share what's in store for that as well. Just not yet. If you subscribe to the channel, you'll never miss an episode. Shameless plug, but why not? That's what I'm here for. Make sure all the links to our platforms are on the website as well, and also in your participant